concepts behind those handlings, the patient handling generally. And there are principles behind patient handling. As healthcare professionals, we do things with reasoning. We don't just do things without reasoning behind it. So we explore those principles or biomechanical principles of handling. How can we apply them in safe and efficient patient handling or transfers? There is risk assessment. There are documented risk assessment templates or frameworks that guides us in terms of when we want to do those handling. We'll look at those templates of risk assessment and how we can use it in our day-to-day practice. We start to identify equipment that will help us in patient handling, some of those common routinely used equipment that will be used in different patient scenarios. And at the end, we will reflect on barriers in the practice and possibly discuss about how we can navigate those barriers, especially in our context, in the context of Nigeria in low resource setting. So welcome. I think we've done a bit of introduction. Now the question is, I believe apart from getting licensed, probably I hope that we are here because we want to achieve something. License is absolutely important, but also I hope we are here we want to achieve something. So the questions that I want you to think of is, what do you want to achieve today? Okay. You saw the advert, you saw probably the outline, and you joined today. Or maybe your department added your name to the list and they asked you to come today. Well, think, what do you want to really achieve today? What do you really want to achieve today? So I want you to think about it. What do you really want to achieve today? But for me, my focus, hopefully today, and hopefully it will align with most of what people here wants to achieve today, is to start thinking about how you handle your patients in your day-to-day practice. That is my focus today, to start thinking of how you handle your patient. But apart from the thinking, which we go beyond that, but at least if I achieve this as the benchmark, that will be good. But apart from the thinking, I hope to give you the skill sets, but also to generate the conversation of handling, patient handling, because it goes beyond the individual responsibility. It's organization, it's systems approach, it's organizational, and hopefully we are pleased to have the regulatory bodies on board who this conversation will go beyond today's session. Now, and that is the last the point that is on my PowerPoint. Training does not make anyone immune. So just having a training today is just the starting point. The systems we build in your practice and the habits we do help us prevent us from the consequences of improper manual handling. And I will hopefully come back to this point at the end and explain it after today's session. Okay. Training does not make anyone immune. Systems and habits do. I will come back to this point. I just want to raise it at the beginning, and all through we will be making links to systems, well, lightly systems, but mainly about you as a person, but also the systems, how the systems will help. And when I say systems, I mean your employer, I mean the policies the government make. All those things are part of the systems that helps in minimizing the consequences of manual handling. All right. Moving and handling in general is a general health and safety term that is used across all industries, not just healthcare. In most climes, in certain countries, it is a requirement in all industries to highlight, of course, not in detail as we do in health and social care, but to highlight how people can move things, such as inanimate object in non-healthcare setting. It covers movement of any load and handling any task. But in healthcare, we're looking at load mainly is patient, but it goes beyond patient. Think of the equipment you are using, and then the tasks including how you move those patients, the lifting you've done, the pushing you do, the pulling, the carrying of the patients we've done. The primary focus is ergonomics and risk reduction for the handler. So you, the person carrying out the task, it's trying to find how we can maximize the principles of ergonomics, our natural physiological body of how our body is built up. And in healthcare, for us, it overlaps with patient. So outside healthcare, it's all the protection of the person that is doing the handling. Because the object, if inanimate, probably the consequences is damage to equipment and not, but again, mainly is to protect the employer. But in healthcare, our patients are are very precious for us, and it overlaps with patient handling. But also, it also applies to the equipment that we use in our day-to-day practice. And it is a regular task that we do in health and social care. And if we don't do it properly or safely, it can cause serious injury to the patients that we carried, but also to us, the staff, or us that are doing the manual handling. Certainly, I think there are definitely probably different stories of MSK injuries or pain across our length of practice, which we'll consider later on. But just to highlight that the consequences is both through the service users or patients and then the staff. Patient handling in itself is a broad term, and it refers to any activity involving the movement, repositioning, or transfer of the patient. So think of everything you are doing with your patient. That is patient handling. And the focus when you're handling the patient or things you're doing with your patient is on the safety of both the patient as well as your own safety during those particular movements. And I dare to say that in health system, and particularly for those that are in attendance today, the nurses and the physios, that is the core task of what we do day in, day out. So I cannot even imagine how one of the primary things we do should not be the forefront of the conversation of our day-to-day practice, how we can do it correctly. Because if we do not do it correctly, it can cause injuries. Or I will say maybe there are people already, it's not even it can cause injury, it has caused several injuries to us. And it has harmed our patients during our service delivery. While we have the intent of delivering the best service to the patient, while we have the intent of making sure that we protect ourselves, but probably not necessarily the lack of knowledge, maybe the awareness or the equipment or the lack of knowledge itself, it has caused a lot of MSK injuries or to the person doing it as well as to the staff, to the patient. So I think today's first starting point is what are the factors that likely contributing to not only to the MSK injury or to injury to us? What are the factors that are likely contributing to in your day-to-day manual handling? We try to unpick those factors in a broad term. It's not, we tried as much as possible not to be research based. I want us it reflecting what we do day in, day out in our clinical practice. So, for example, I'll bring out those. So one is the repetition of actions. Repetition and actions. We said, and I will give opportunity for people in this platform to share their own personal experience or thoughts around these bits, but I will going to give some examples of what I mean by this. Repetition of action. We said my patient handling is our core task, so it's probably inevitable that we cannot avoid it. So the likelihood of us doing these things over and over again, it's there. It's very high. Repeated movements can cause our muscles to be fatigued. Get tired. Repeated movement, overloading our tissues. So it's the cumulative strain over time when we are doing these things over and over and over again. So here is not the question of whether we are even using a wrong technique. No, it's not the question whether you're using a wrong technique. Yes, it's possibly you are using the right technique or maybe wrong technique plus repetition, but the fact that we are doing it over and over and over again, it is likely to lead to overload of tissues. It's likely to lead to cumulative strain, especially when we do it on a very short period of time. So one thing is repetition of action. What is the risk? What does the factor, how does it increases the risk of MSK injury? Is the repetition of action over a period of time, cumulative strain. And it might be something that we don't think about it. And for this, what are the possible mitigating strategies or what are the possible controls we could do? Yes, it's our job. Yes, we will do it. Yes, oh, absolutely. But there are possible ways we can minimize the risks to us and our patient will benefit from it. I know workload is something that maybe a lot of us wants to hustle hard. A lot of us wants to make sure we finish our patient as quickly as possible. But on the long term, it has consequences. So possible mitigating strategies, I will call it, or control measures is, have you considered rotating the tasks among the team members? These are ways that it can break the task and make it manageable. So maybe instead of you doing the same thing over and over again, because the same muscle group are being recruited, you can switch and then do another task. So instead of you doing this particular task that involves a lot of you using one of your hand or two of your right hand or left hand, you can switch and then move to other tasks. And that will now break that repetition of action. But in manual handling or in patient handling is the question of, is it possible to use an equipment? Have you considered the use of equipment to reduce the repetitive force? That would be an excellent in an ideal world, but I understand sometimes equipment is a luxury. So it's a question of, have you considered using an equipment to reduce the tax? Or is it a question of planning? Have you considered your workflow to avoid unnecessary repeated repositioning? Our patients, we have to go and adjust them and things like that. Or encourage micro breaks and stretching. These are possible mitigating strategies of repetition of tasks. And I will also say for this today's training is in maybe in your setting, maybe it's not only about you, the therapist, and it's not only about the patient. I'm aware that there are patient relatives that are heavily involved in patient care. And if we want to look at a systems approach or a broader picture, it is also in our self-interest that we encourage them to do things that are safe so that tomorrow they then end up becoming our own patients. I don't think we want that because we want to be preventative. We want to promote a system where a good practice and it reduces the influx of patient. Overall, systems approach encourages us to look broadly. So some of the knowledge today might not necessarily apply to you, but certainly to your patient, and then there are carers that are helping them. So that's one example. Think of the factors that will influence your practice. What are the why it will it affect or increases the risk of MSK injury or injury generally, and what are the possible control measures? The second bit is another example that I will bring before I hand over the mics to those in the platform is prolonged static posture. So the first question I will say is with prolonged static posture, the question I will ask is why it increases the risk of injury. Why does prolonged static posture increases the risk of injury? A static posture will lead to a sustained load on a particular joint or muscles. It increases the discomfort and reduces probably the circulation. Possible control measures is to adjust the bed height, chair height, foot placement to stay in neutral posture, or maybe just incorporating movement, shifting weight from side to side, forward and backward, or just stepping, or changing stance during tasks. I think some of us unconsciously, maybe we've done this when we are standing in a queue. Certainly some of us that went to universities, when we're standing on the queue of either registration, accommodation, or anything, if you stand in a long period of time, your legs sort of get numbed and then you have to move forward, backward, trying to adjust yourself. So these are all things that will help reduce the likelihood of injury, especially when in our day-to-day practice. Just to be aware of it, or just for our patient relative to be aware of it, to educate them on how they can reduce that likelihood of injury. Adjusting the bed height, or where possible, increasing the person to move every few minutes, 30 minutes, or ideal definition is after every 1 hour, try to break that cycle and move. So the next bit I will probably bring it. So I'm going to bring quite a few of them on board. So the next bit is bending, twisting your back in an awkward way. So the question is why does it increases? Why does this particular activity increases the risk of injury? Lifting, transferring dependence patient. Why does it increases the risk of injury? And what are the possible control measures? Continue to walk when injured or hurt. Why does it increases the risk of injury? And or when it hurts? So I will probably at this point really like to hear from your experience, starting from the first bit, bending or twisting your back in an awkward posture. We want to do these things very quickly, but why does bending or twisting increases the risk of injury? And is there anything we can do about it? I will invite anybody from the platform. You can unmute your mic or you can put it on the chat box. So the second three points on the board. So two things. Why do you think this increases the risk of injury? And what are the possible control measures that we can use to minimize this? Anybody? By all means, you can mute your mic or you can put it on the chat box.
Hello, sir. Can I speak?
Yes, please. Carry on, Mr. Suleiman.
Good morning, sir. Good morning, everyone.
Yeah.
I think this bending of and twisting in an awkward way, definitely it will affect the normal biomechanics of the human body, thereby increasing the risk of musculoskeletal injury. And one way to mitigate this is for the clinicians for us to adopt or to go by or to abide by normal ergonomics in terms of lifting our patient, in terms of doing our activities in the clinic. Thank you very much, sir.
Okay, thank you. Do you want me to still probe a bit further, Mr. Suleiman? Are you okay just to ask a bit of follow-up question?
Yes, sir.
Okay, so you mentioned about normal biomechanics way. What are the normal biomechanics way? And apart from, is there any other things we could possibly do? Just what are the, if you have any idea on that?
Yes, the normal joint alignment, the normal alignment of the spine.
Yep.
Usually, I think that's what I can say about this.
Okay, that's fine. Thank you. Thank you. Anybody wants to add on that, please? So bending or twisting your back in an awkward way, lifting or transferring dependent patient, continue to work when injured or hurt. Why does it increase the risk of injury? And what are the possible control measures? I think Suleiman have given us an excellent suggestions. I would like to hear more.
Hello, good morning.
Yeah, good morning.
I will say that it increases the risk of injury because of, like in the case of continuing to work when injured or hurt.
Yeah.
Already the tissues are injured, and then a repetitive action surrounding the injured tissue can only make it worse because there should be rest to allow for healing.
Okay.
And then what can be done to mitigate it is rest.
Okay.
Or maybe even, asking that your station should be changed. Maybe you can begin to do a walk in an area where it does not involve the injured part.
Mm.
And then in the case of lifting or transferring dependent patients,
Yeah.
of course, like in lifting, there is that forward flexion, bending. And we all know that it causes excessive strain on the spine, especially around the lumbar region. So doing that can cause, spine disorders, or it can even cause strain around the spine region. And even it depends on the weight of the said patient being lifted. So it's not healthy because of the weight distribution as against the base of support of the therapist now.
Okay.
So, and we can mitigate that by using a hoist. There are machines that will aid in avoiding such injuries. And I think for the bending or twisting your back in an awkward way, the earlier person who made the comment, I like what he said. It's something that we know it is against the natural biomechanical standing of the human body. Bending and twisting are not, will I say, to be repetitive, or it's not normal movement for the humans when, and especially when load is involved. So I think that to mitigate that as well, maybe it will be where multiple people can do the task. I think you should seek for assistance. Maybe not one person, but two people. It will mitigate that.
Okay, thank you. Thank you, brilliant. Thank you, HOD FMC. Yeah, I think that's good summary of the three. And I will just add a bit. I think just to expand, one is for us to be aware of those things, but two, is just we are the expert control measures. I will start with the bending and the twisting your back in an awkward way. And I think what the other people and said, it's good, the normal spinal, neutral of the spine, the normal curvatures of the spine. So why it increases the injury is we talked about the awkward posture, the muscle strain, the spinal torque, and possible control measures. Yes, the neutral spine, like Suleiman mentioned, like Kelly mentioned, but also instead of bending and twisting, especially instead of twisting, one of the reasons why we twist our back is because we plant our feet on the floor. So instead of us when we are turning, we turn with our feet planted in the floor, on the floor. Instead of that, think of moving your feet, okay? So move your leg instead of just turning. And then we can do some steps and then you turn around. Bending, we tend to bend when an object is far from us to pull it closer, okay? And that's one of the things we do. Sometimes it's just we find it easier to just do things, neglect maybe with limited, sometimes it's quicker, easier. So try instead of reaching out to pull an object that is far from you, think of moving closer to reduce the lever arm and move the object close to you. And that will reduce the length of the lever, which will consider the implications of that in you pulling, because it increases the amount of effort your muscles will do. So think of that as mitigating structure. And I think probably Gail mentioned, sometimes consider rearranging the room layout to improve access. Maybe because the room is so narrowed and squeezed that we're just trying to squeeze ourselves and find a way of doing things. Instead of us trying to manage things, sometimes it's just how we rearrange things. Clear access, have a space for all those movements and things like that. Sometimes when you patient relatives, maybe when you go back to your ward today, or not, yes, possibly next week, and when we do, see how when patient relatives or when we want to see patients, or when our assistants wants to see patients, and certainly we should look after our assistants because when they are not there, we are the one doing the work. You will us trying to bend over the patient because the bed height is low, and then we bend to all the way down. So instead of bending, we try to lift the bed up to our waist height. That will reduce the amount of time that we will bend to pull a patient, and that will reduce that part of it. So bending, twisting, and back, rearranging the room, bring the object closer to you, that will reduce the bending, raise the bed height, that will reduce the bending, or trying to step using your legs. And yes, as people mentioned, keeping the neutral spine in place is always the basic principles of manual handling, keeping your neutral spine to maximize that biomechanics. The next bit is talking about the lifting or transferring dependent patients. And by dependent patient, we mean patients that is doing less and you are doing more. The patient is doing less and you are doing more. So that is the definition that by dependent patient, where the patient depends on you. And load, the high load, and it might increases your risk of injury. It's a lot of load that you will lift. When a patient is relying on you, it increases the amount of load or the weight that you pull or push or whatever maneuver you're going to do. And another thing you probably want to look at is the predictability of the patient. If the patient can abruptly be impulsive or change their behavior halfway through the movement, that will certainly affect the way you carried out the movement. So think of possible measures. Yes, equipment, which I think somebody have mentioned already here. So that's brilliant. One of the ways to avoid dependent patients is use of equipment. And equipment, it all depends. There are a range of equipment that you can use, all depending on the level of patient's dependency. all the level of the patient's dependency. However, we know resources are limited and sometimes those equipments are luxuries. And if that is the case, then you need to think of how you can assess the risks to minimize to make sure that you are aware of the process and to minimize the injury, trying to find the safest method to move the patient. Could be use of more than one person, could be use of a different techniques as we were doing, anything that you could do to minimize the risk to you and to your patient. Depends still on dependent patient, which is the next one. What we encourage is avoid manual lifting where possible, unless the patient can take most of the effort. By definition, you avoid manual lifting where possible, unless the patient can take most of the effort. Also, I understand sometimes in different resource setting in different setting might be difficult, and that's why you assess the risks and try to find out how this you can mitigate the risks. The last one on the fifth one is continue to work while injured, which is obvious. And I think that also was highlighted about continue to cause damage to the tissue that has already been injured. But yes, that is part of it. But one of the other aspects is pain reduces the quality of the movement or the technique we will do. Think of it. Some of us, when we have pain, we avoid using a particular position so that we don't trigger the pain. So that moves us to compensatory movement pattern. And the more we move or we moved away from our normal biomechanics, as I think somebody mentioned, the more likelihood of further injury. So the fact that we want to push through let me just finish it. I need to do these things. When you are injured, it just increases, apart from causing more damage to the damaged tissues, it will also cause more new injuries because you will use compensatory abnormal techniques that will cause more injury to the person. And possible control measures is what you guys have mentioned, but where possible, reporting, modifying duties, educating the team just to avoid push or create if in the systems. And I think there are a couple of HODs here, and I think the registrar probably have exited. There are people here, and it's creating that culture where you can trying to support your staffs, find their limitations, and trying to find a work that will work for them as a manager. So yeah, thank you for those that contributed. And the next one I probably want us to consider is reaching or walking away from your body, which is, I think, the same thing that we talked about earlier on. Why it increases the risk, the more we reach or away from our body, it increases the spinal strain, reduces the control over the patient movement. Where possible, we try to keep it as close as possible to ourselves, clear the object or obstacles that makes us to reach over, use equipment to bring the patient close to us, ask two people to use it. Another thing that probably is the last two bits I will bring it is high caseloads, rushing, walking, walking while fatigued or tired. And the same thing is trying to prioritize the tasks. Maybe ask your team, spread the tasks, take short break. And I think this is where, as a leader or manager in your workplace, you can think of how you manage the workload among your staff if you really want them to come back the next day. And then the last one, which is quite very important, is inadequate or missing risk assessment. All these, the ones that I've mentioned earlier, one of the main one is inadequate or missing risk assessment. When we do not assess the risks, or whether you as a clinician or the service didn't assess the risks, It can mean wrong technique. It can mean absent or wrong equipment, and all this will increases the likelihood of injury because we don't know the risks, or we did not identify the hazards in our risk identification, and that will exposes the patient, the service user, the staff doing it, or the carers, family relatives to harm. And we will consider some of those risk assessment frameworks that we can use before every movement, or some quick assessment that we can do. But certainly, there are places of work that usually have. What I will encourage is, if your place of work doesn't have, you can have a documented risk assessment protocol or procedures that you can use to mitigate the risk. This is just some of the reported factors that contribute to injury in the literature. Now, the question I will ask is there anything that anybody wants to add to the list? Is there anything that anybody wants to add the list? Anything that you think exposes you to the risk of injury? Okay. Now, the second question is, from your own experience, either from you or from your, not necessarily you, but what you observed, what are the highest, what is the, if you're going to rate these things, which one will you rate as the top item that causes the risk of injury in your practice? What are one of the main things that causes the risk of injury in your practice? And I think, can we all put in the chat box, or you can unmute yourself and tell us? So in your own view, what is the one thing that you think is the number one culprit of causing risk of injuries? Yes, Chima.
Can I talk?
Yes, you can talk, Mr. Chima.
Yes, I think based on my experience, this bending or twisting back in an awkward way,
yes,
should be the number one factor that is leading to MSK injury.
Okay. Okay, well, Mr. Suleiman is the one talking. So we're going to make a list and prioritize. So Mr. Suleiman said bending and lifting. So that will be one of our items. I want to collect the item and we try to vote on them. Okay. Mr. Chima, your hand is up. Oh, Florence, is it? Sorry. Florence, your hand is up. Bending and lifting is the number one cause risk of injury. And I think somebody added on the chat box, thank you, did mention about, Mr. Isaac mentioned about poor interpersonal communication among staff. Absolutely agreed. Let's add that to the list. Apart from mine is another communication, because when you're working together, okay? Yes, Mr. Kelly.
Yeah, I will say for me, continuing working while injured or fatigued.
Okay.
Thank you. High caseload, yeah.
High caseload or both?
Yeah, I think there's a point that carries all that. Second to the last, high caseload, working while injured, / fatigued. Yeah.
Okay. So that's two. So we have repetition, bending and twisting, according to Suleiman, and high caseload, rushing, continue to work while fatigued. Thank you. Anybody wants to add to the list, or is it the two that we say they are the biggest culprit? Lifting dependent patient, okay. Okay, thank you. Thank you, Mr. Suleiman. Number one is lifting dependent patient, okay. Okay. I'm going to put high caseloads for care. That's another one. And then bending and twisting. I believe Suleiman's own is bending and twisting. Lack of organizational ergonomic. Is that the first one? Okay. So we have 4 different items. Can you please just go to the chat function and use the emoji? Just click the thumbs up on the chat function. If you agreed with any of the one that was mentioned, just click thumbs up on them. So try to identify the one you believed is the highest one. Okay, somebody mentioned organizational function so far too. Okay. Let me capture this very well. Okay. Yep. Try to go and click on the one you've believed is the highest one. Okay. Bending and twisting. Okay. Lack of organizational ergonomic. Okay. So I think we don't have lack of organizational economy in even the list, which is true. It's part of the things. Okay. Thank you. So what I think the main conversation for us today is to understand that those things exist, to bring to our awareness, and it's not something that we want to wish away, because once an injury has occurred, it's difficult to reverse it. So if you are lucky that you have not find yourself in the risk of injury, or you are not suffering from any sort of injury at this stage, then it's trying to avoid it going forward. Yes, there are natural wear and tear, but where possible, avoid it. But even if you find yourself trying to mitigate it going forward, trying to find a way of avoiding things that will cause further injury. But apart from you is the benefit of it. So the benefit, apart from you, it's also your patient and your service users. And that takes me to my next point. The benefit is there is a double-edged or maybe triple-edged benefit to implementing patient handling. One is to us as the clinicians or the healthcare workers, whether the physios, the nurses, the healthcare assistants, or whoever it is that is involved in helping those patients. It prevents us, it preserves us, it helps us prevent us from risks of injury. And it helps the organization that you are working in from sickness, absences, and losing staff, or staff not even performing because they are afraid of injuring themselves or further injuring themselves. But also the other side is our patients. Our patient probably have suffered the consequences of our lack of proper handling techniques, whereby we cause further injury to them instead of helping them. And then the carers of those patients, we see them doing those things, but we didn't correct them. I think it's important we intervene, we correct them. It's part of our rehabilitation interventions, I would say. How they should do it, what is the implication? But what I will also mention is that some of those handling techniques are treatment in itself. When you allow the patient to be able to do things more for themselves rather than you doing it, you educate the patient that they need to do more for themselves. You educate the service users, the relatives of the patient, that they need to support the patient to do more for themselves, not taking away the ability of the patient to do things, which I think naturally in our society, when somebody is sick, we want to do everything for the person. But in handling, the more the person do things for themselves, the better for everyone. So yes, they are ill. You assess the risks and see what they can do for themselves, and you meet them halfway. So the message is, where possible, patient do more, and then you intervene using safe techniques. Service users, relatives intervene using safe techniques. And thank you to those who have added those points, new points on the list that is not on my PowerPoint. The poor interpersonal communication among staffs, the lack of organization. Now, let's come about the principles that will guide your proper handling techniques. What are those principles that will guide? What are those terminologies? Some of those concepts that will help in proper handling techniques. One of the terms that I will mention is the line of gravity. Line of gravity. And by line of gravity is, if you look at the picture in the middle, there is a red line right from underneath the belly button of the person all the way to, it falls right between the legs of the person, the two legs of the person. So the line of gravity, by definition, it's an imaginary line. When we are standing, we don't see it. But this one is just a line that was drawn for illustration. It's an imaginary vertical line from the center of gravity. And by center of gravity, it means it's a point where the mass of the body is concentrated, where our body is the heaviest. So the center of gravity is expected that when you balance an object at the center of gravity, it will stay at equilibrium. If you balance it at that particular, so it's where our mass is sort of concentrated. And by this picture, let's say it's just underneath the belly button where the mass of the body is concentrated. And when you hold that object there, it's sort of evenly distributed. So the line of gravity starts from that center of gravity all the way to the ground or surface where the person or object is on. And we all know gravity. So it is the direction that the gravity is acting upon the person. Now, because that mass is there, now gravity is pulling all the way to the ground. Now, the center of gravity, in this picture, lies within the base of support or within the individual. It sits within the individual, but our center of gravity does not need to lie within the physical bounds of the object or the person, where our mass is distributed. And that's where our muscles have to work to counteract it. So what is the interaction between our line of gravity, base of support, and center of gravity? And our base of support, by definition, is where our body is being supported on the floor. So if you look at the picture on the down where the person is standing, the original picture, the base of support will be the 2 feet on the floor and the surrounding area. Wherever the circumference, wherever the body is in contact with the floor. Now, the location of the line of gravity in relation to the base of support. So the base of support, so the line of gravity is the red object. So the location of this red object, the line of gravity, the red line rather, in relation to how we are supported. So the base of support means the point at which we are in contact with the floor, has huge influence on how we are balanced and stable. And in anatomical position, the line of gravity, which is the red object, is between the legs and feet and right under the person. So the person and the illustrated person, we can see when they are standing, and that is what we call our anatomical position. When you are standing in this anatomical position, the line of gravity falls right within the base of support. And at this, by definition, we are very stable and we are balanced. And the closer the line of gravity is to the center of the base of support, the better the balance the person is in this position. And by definition also, by the other concept, the shorter the line of gravity, the more balanced we are. The longer the line of gravity, the more our body has to work. But if the line of gravity falls outside the base of support, the person must provide a corrective muscle action. Usually our movement, well, we will fall. For example, now, the picture of the three ladies at the top, we can see the person holding the ball trying to make that sharp bend. Now, the red line, that is where the line of gravity is falling, because we say is a vertical line all the way to the floor. And where this red line starts, that is where the center of gravity is. That's where the mass of the body is equally distributed, because the way the person is positioned. And then the legs, where her legs is barely touching the floor, that is her only base of support. So the person has narrow base of support, and then the line of gravity is displaced outside the base of support. Now, by this, the person is highly unstable, and by common sense, we will say, yes, this is unstable, but the principle behind it is this person narrow base of support, line of gravity displaced outside the base of support. And without the muscles of the person doing, then the likelihood is the person trying to fall. And then the other bit, which I think we've talked about, is the lever system. The longer the lever, the more difficult we have to lift an object. And maybe you try it, and I think we can look at it. If you are holding a tray, just by holding a tray away from your body, all your arms stretched, you will see your muscles trying to complain, your hand muscles is trying to strain, and if you are able to hold a tray away from your body for example, for 20 minutes, if you bring it closer to your body, the same tray, the same weight, you might be able to hold it for a longer period of time, 30, 40, 50 minutes, because the far away it is from your body, the more your muscles will work to counteract this gravity and the weight, but the more closer it is for your body, the less your body is likely to work. So the implications is, and in relation to what we considered earlier on in terms of factors that contribute to MSK injury, is we said bending is because we are reaching out across an object because it's far from us. Wherever possible, try to bring your body close to the object you are moving. If it's your patient, where possible, try to move your body closer to the patient by using different techniques, using slide sheets, moving closer rather than stretching your hand, because it strains your body. And once you reduce that, it reduces the muscular effort. And the second bit is, where possible, engage your bigger muscles rather than relying on your arms alone. Your legs muscles are the ones that they are mainly your bigger muscles. And in terms of transfers, the application of the same principles in transfers. In sitting to standing, when you're transferring patients, where possible, you can use the same principles that affects the displacement of the body to your advantage. When you are standing a patient, trying to ask the patient to lean forward, displace their center of gravity forward, so that they are already in that position whereby their body is more likely to move forward with less effort from you or from the patient as well. We said the wider the base of support, the more stable an object is. When you are moving a patient, or you are handling a patient, or when your therapists are handling a patient, or when carers, educate them to use a wide base of support. And then the lever system, trying to move an object close to you. In bed, where possible, the patient is moving, try to use slide sheets. And slide sheet doesn't have to be anything sophisticated, any slippery object on the bed to reduce friction. Sometimes your patient may not be able to move in bed in a normal sheet, but once you put a slide sheet, you will see that you don't need to pull the patient and they can swivel themselves. And then maintain a neutral posture while guiding the patient. And by neutral posture, if you look at your spinal curvature, you have the lordotic curvature at the cervical spine, you have the kyphotic at the thoracic, you have the lordotic at the lumbar. all you need to do is maintain those natural posture while moving the patient. We said instead of twisting your back, you lift your feet to avoid twisting and bending. One of the main things that we highlighted that causes injury is bending and twisting. So to avoid that, we lift our legs when moving. So what are the principles? And I just to summarize the principles of efficient. One of the things that principles of efficient moving and handling is one, some of those things we need to plan ahead. We do things almost on autopilot. We just want to move things, especially when we are young. We have a lot of muscle strength, energy to do it. But again, if you do it for a long period of time, then it's going to be a different story. So think of planning ahead. Always plan ahead. Use the things we've talked about: stable base, good posture, keep object close to you. We've already considered what does it mean, what is the implication. Bend your knees and hips if you don't have any hips and knee injury. Hold the object securely. Move smoothly. Lift your legs instead of twisting. And communication. Somebody mentioned communication as well. So good communication. This good communication is quite very important when you're doing a movement more than one person, or even when you are moving the patient. If you are not communicating with the patient, among the staffs, apart from communication with the staff, when you are moving the patient, it's also important to communicate with the staff. Good command. It helps the patient to be able to understand what you're saying and how to follow your instructions. And always know your limits. Always know your limits. It's not about using your strength to pull a lot of objects. Always know your limits. There is a defined weight that, based on research, you are expected to carry. There is no point in you going beyond your limits where possible. If the weight is too much, ask for 2 people to lift the object. Use equipment instead of using yourself. And those weight changes depending on how you carry the object. Those weight changes depending on how we carry the object. And there is a gender difference to those weights as well. In this picture, underneath is, now with the knowing the limit, the 2 pictures, note the difference when seated and when standing. Now, when the person is sitting, when these 2 objects are sitting, the weight they carry is less compared to when they are standing. And simply because there is that dynamic base, they can be able to move their legs, use their leg muscles and all those things. That changes the amount of weight they carry. But as they are sitting, that also reduces the amount of weight they carry. The 3 kg is for the female gender, the 5 kg is for the male gender. But there are standard weight limits that you can see when you're carrying an object. Of course, in manual handling, we always encourage, where possible, avoid. And that will take us to risk assessment, because it's all about risks. In reality, we cannot avoid. In fact, we have chosen a profession that we will always come across those handling techniques. Patience is one of the core tasks that we will do. Risk assessment, assessing the risks. Now, in terms of the risk assessment, there is what we call hazards, and hazard is anything with the potential to cause harm. So when you are looking at what are the things that are potentially likely to cause harm, it's not necessarily that a harm will occur, but it creates that possibility. And based on that possibility, you will act. In a formal documented risk assessment, you can put those likelihood in the medium risks, high risks, and low risks. And this probably, I would say, is the responsibility of organizations, is the responsibility of those departments, And if you are a HOD here, I think it's something you should start thinking of, having a paperwork and then pushing it forward. It doesn't have to be your CMD or the government or the Minister of Health. You can start influencing those things right from your unit, right from your department, while you assess the potential risks of your staffs where possible, maybe patients where possible. Now, the risk is the likelihood of the harm occurring, and based on the hazard identified, you categorize those risks into the severity of either the harm will happen to the patient or to the member of staff, or it will not happen. Now, my question is, what do you think could be a hazard when completing in your moving and handling? What are the possible hazards when completing the moving and handling? What are the possible for you? Just have a think. When you're doing moving and handling, when you're moving your patients, what are the hazards? What are the things that are likely to cause harm to you when moving the patient? When moving your patient, what are the likely things that we think will cause harm to you when completing it? And I would really like to hear your voice. Yes, Suleiman.
Weight of the patient, sir.
Okay. Can you expand on that?
Yes. Heavier patients can cause or can stand as harm or potential harm to the therapist in terms of lifting them up.
Absolutely, yes. So weight of the patient, yes. And you can put it on the chat box as well. I think we've been doing this day in, day out. So from your own view, from your own practice, what are the things in your clinic, or when you go back on Monday, or when you've been through this week, what are those things that you think are likely to cause harm to you when you are moving your patient? So one is weight of the patients. Okay, poor handling. Okay, poor handling. Okay, limited space. Absolutely. Yeah, thank you, Rox. What are the things? You can unmute yourself or you can add. What are the things on the chat box? So we have two. What are the things, or three in the list, do you think might cause harm to you? Okay, bodily fluid. Absolutely. Yes, absolutely. What are the things? You guys are the expert. I think some of you we've been practicing, or maybe from your experience, what are those things that have caused harm to you, that have caused an injury to you during your practice, either likely to cause harm or have already caused it, really? Okay, what are the things? So there are quite a lot of things that could cause harm to us apart from the one. So one is, Suleiman mentioned about heavy patient. Now let's categorize those things. Uncooperative patient, yes. Let's categorize those things into one. Let's look at the patient. One, Suleiman mentioned the patient, heavy patient, awkward, dependent patient. Yes, they are likely to cause harm to you. Two is cognitively impaired or uncooperative patient who doesn't follow instructions because of their impulsivity or unpredictability. They are also likely to cause harm to you. And then we talked about bodily fluids, which I think Roxana have added. But apart from the bodily fluid, think of the IV lines, medical attachments, catheter. All those things are likely to cause harm when you're moving the patient. Patient pain, for example, dizziness, instability of the patient, they are likely to cause harm because if a patient is in pain, they might just react differently. If they are dizzy or they are unstable, they are likely to cause harm. So one factor is we look at it is from the patient aspect. The second bit is you probably want to look at it is from the environment aspect. We talked about slippery, somebody just put slippery floors, uneven surfaces, cluttered environment, space. Somebody mentioned about space. Cluttered environment can cause harm to you when you're moving. Equipment, furniture, bins, blocking the path. When you just want to move the patient and you don't care about the environment. So it's something we need to be aware of. Blocking space pathway might cause harm to us. Poor lighting or excessive noise. Tight spaces, bed heights, and then the equipment. The equipment we use might be damaged, faulty, or incorrect equipment. All these things might cause harm to us. The staff member, we talked about, I think HOD and other people talk about the poor posture that we do, are all the things that will cause harm to us, but also to our patient. Lack of communication, I think people mentioned also. So all these things are the likelihood. And then the task itself, when we're doing it, needing to lift manually rather than asking for assistance, all the things we talked about earlier in the starting of likely injury are the likely things that also will cause harm to us. So how do we minimize those risks? How do we minimize those risks? There is what we call the traffic light system. And always, like I said, always in patient handling or in manual handling, avoid all hazardous movement. Avoid all hazardous manual handling where you can. Always avoid. That's the first principle. Avoid. And the red means you eliminate the hazardous where possible. Completely avoid it. Any activity that will present as a risk of injury. Now, I'm not saying you should lose your job, but in terms of saying that you can't do work, do things in your place of work. But what I'm saying is that it's good practice for you to discuss when you think this is likelihood to cause injury, or if it's going to cause injury, where possible, avoid it. And you can avoid it by speaking to your manager, trying to figure out what are the, where possible, avoid it. If it doesn't need to be moved, don't move it. If it doesn't need to do things, don't do it. But if you can't avoid it at all, you assess the unavoidable handling techniques. You assess the unavoidable handling techniques. And that includes analyzing the tax in the using the tile system, which will look at it. What is the tax that you need to do? Earlier on, somebody mentioned about heavy patients. What is the tax that you need to do? Moving patient, for example. What is the load of the patient that you are moving? What is the environment that you are moving the patient? What is the capability of the person that performing the task? All these things are things that you can have a look where possible. And then the actions, take actions to reduce the risk of the injury. Take actions. If you assessed it and then you find out that this is the risk, then take actions to reduce it. You can think of minimizing the steps using what we talked about, the mechanical aids, redesigning the workspace, improving the technique or review or training your staff. And then always, as a principle, always review regularly whatever you've done. Reviewing regularly is always a good practice, whatever you've done. So that to avoid, review regularly because those things will change over time. So these are roughly, first is avoid, second is assess, and then once you assess, you take actions. Now, these things, in terms of what you do, there is a formal documented process of risk assessment in other settings, but also there is an informal process of risk assessment that we do day to day. Now, the formal risk assessment, I would say maybe certainly in other settings in particularly Nigeria, it might be something that has to be developed, but the informal one is something that I will 100% encourage you to do. The formal one, it's usually a systematic evidence, a process that you have a bulky document that you go through it to identify the potential hazards, where you're looking for potential sources of harm. And then once you identify those hazards, you evaluate the likelihood of harm and severity of injury, thinking of identify who may be harmed and how, and assess the risk level and determine the precautions for the person. And you implement measures to control the risk. So sometimes it might not be you necessarily, it might be your organization where you document those things, and then there are a suggestion of how to reduce those likelihood of injury. And then that will be reviewed. Here, it's in other countries, it's a legal requirement for you to use the formal assessment, and it forms the core component of safe practice, both in healthcare and education in most clinical environment. The formal risk assessment, I would say, is a systems responsibility. And when I say systems, I'm referring to the organizations, your employer, the regulatory bodies, all those things contributes to the system that helps in having the formal bit. But like I said, apart from the formal, we have the informal one. Well, not the informal one, and there is also the dynamic risk assessment. There is the dynamic risk assessment. And then there is also the dynamic risk assessment, which will be the emphasis of what we will be doing, because I think it's the most things that we will have influence on, or something that we can take it quickly and apply it. But the formal one is something that organizations can take it on board and then push forward. And it's something that we will be advocating in most settings in Nigeria, certainly. I'm aware we've been talking for almost 1 hour, 30 minutes. I'll probably pause here. When we come back at some point, we will look at the dynamic risk assessment and how to go through it. Apologies I think on the advert, I put 9 a.m. I didn't put the time zone. I think 9 a.m. Nigerian time. I'm aware there are other people joining us from a different time zone. And maybe the 9 a.m. might be this 9 a.m. is different from in other countries. So we started, maybe UK time, we started 8 a.m. and Nigerian time, we started 9 a.m. So we're going to have a quick 15-minute break, what I call screen break. And this is roughly around 9:30 or 10:30. We're going to come back by 10:45. So 15-minute break. But before we go in, is there any questions so far? Okay. If there is no question, for those that are joining a bit late or having difficulty with the internet login, hopefully there is the recording. You can certainly go back to the recording. And if you have any question, I'm happy to answer it. But if not, let's have a quick 15 minutes break and see you guys all by, okay, yes, those Buki, yes, your hand is up.
Bukayo, yes. My hand is up.
Yeah.
Yes, sorry, it's not about the presentation per se. I noticed while you're taking your presentation, sorry, my bad manners, sorry, good morning. Good morning, everyone.
That's fine.
While you were taking the presentation, I noticed you were breaking. I don't know if it's just me or it's everybody, because at times we are not getting the smooth conversation of your wonderful lecture, sir. I don't know what I don't know, maybe it's the internet. I don't know, maybe it's the app we are using or something. I don't know. Okay. It's just a suggestion, sir, and my observation. Thank you.
No, that's a good one. Maybe just to confirm, I'm just other. Am I? Is it flowing, or is there a break in the conversation so that before we come back, I can try to rectify it? Are other people having the smooth, or it's smooth on my end? Okay, thank you, Omodara. It's smooth. Can I have another confirmation, please? Okay, it's clear, no break. Okay, thank you. So,
All good.
all good. Okay, thank you. Okay. So, apologies, Mr. Bukayo. I think if the network is not working, sorry, and maybe you try to rejoin later after the break. Okay. So I will see you by 10:45, please. Thank you. Thank you, Suleiman. Thank you. See you all by 10:45. All right. Welcome back from break. And people are joining back. So welcome back. Before we go on a break, we were talking about risk assessment. Just to make sure that I'm not talking to myself, if you are back, can you put a message on the chat function, please? Just put a message in the, just to make sure that people are back, really. Okay, yeah, good, thank you, Mr. Charles Keltuma, yeah, thank you. Thank you. Thank you. Brilliant, thank you. All right, so let's continue. Before we went on a break, we were talking about a formal risk assessment, which is a document that it's this that you will have at a place of work. Now, but what we can influence and what I think we come across daily in our practice is the dynamic risk assessment, and it's not necessarily the paper-based. And dynamic risk assessment, by dynamic risk assessment, it's something that we keep on doing, is a continuous and adaptable assessment that we do day in, day out in our practice, where we ensure safety for both the patient as well as us during our day in moving and handling or handling of the patient. So even though we have a formal risk assessment, which may or may not exist, we must, as individuals, when we are seeing those patients, assess each situation dynamically before acting. Or every single time we go and see patients, support patients, not even patients, moving equipment, whatever we are doing, we need to assess those situations to make sure that it's safe for us to do those things. And this does not require us doing a paperwork or filling a paperwork. It's all about thinking through the hazards and the risks in real time. So a patient, you just bump into a clinic, a patient is standing on you. You just quickly, for example, look at around your environment. Is it safe? For example, just look at your patient. Is the patient stable enough? We talked about those factors that will influence your assessment. Look at it, and do you have the right equipment and help to do the assessment, to carry out the movement, or do you need equipment and help to carry out the movement? And for the assessment, there is usually an acronym just to help us wrap our heads around it. There are acronyms that we can use to make sure that we have a little checklist to make sure that everything is covered. And the acronym stands for either TILO or ELIT. They all stand for the same thing, TILO or ELIT. ELIT, yeah, they all stand for the same thing. The T stands for the task that needs to be done. So what is the task that needs to be done? Or what is the task that you will be performing? So that's the T. The I stands for the individual performing the task. And this is where it's talking about us as individuals or persons performing the task. The L stands for the load. And in our situation, it's the patient that we are helping. But our load is not limited to patient, because there is what we call animate and inanimate object. It is possible in our space, we will be moving and handling bed equipment, crutches, wheelchairs. All those things are parts of the things that we need to consider when we are doing the handling. The E stands for the environment where the task is being performed. And then the O, which is for the tile, stands for the others or equipment. And the Lth, one of the E, the same acronym, the Lth, the first E stands for the environment, and then the last E stands for the equipment, which is nicely showed in this picture. So they are all the same. Think of tasks. What is the task that needs to be performed? Think of the individual that is performing the task, and that is us in this situation, or that is our patient relatives in the situation, or it could be your assistants in this situation. The load is our patient or the wheelchairs, the environment where we function, and then the equipment. We will take turns to look at each and one of them in detail. Now, this is just an acronym to help us guide our day in, day out assessment. And we can do it as quickly as possible. So what is the task? The first thing is the object that we need to move or the persons that we need to move. The first thing you need to always consider is it necessary to carry out the task? How urgent is the task and how often is the task? We talked about repetitions of a task can lead to injury. So how often are you doing the task? Are you doing it over and over again? Can the person help, or does it involve taking the full body weight? Where possible, always encourage, if you are moving a patient, let the patient do as much as possible, and then you come in to help the patient. If you are doing a task, what is the point A to point B where you are moving the task? What is the distance you are traveling? Because it has an impact on the exertion. It has an impact on how long you're going to hold or take the object. So what is the distance that you will be traveling? Is there a height difference between surfaces? If you are moving a patient from one bed to the other, what is the height differences in those beds? Do you need to adjust it? Will it involve stooping, twisting, or turning? And we talked about the implications of stooping or bending, turning, or twisting. So think of the task. Does it involve any of these things and its implication to the individual who is doing the task? Are there other handlers necessary? So if you are not the only person you are involved in, earlier on we looked at communication as one of the problems of patient handling. So are there other handlers involved? Do you need to communicate with other people when you are performing the task? And is the person that you are performing the task in an accessible position? We talked about the space in patient, the space at which you do the task. How tight is the space? Do you have enough space? Can you reposition the person to carry out the task? All these things we need to consider when you're doing the task. And then what is the safest and most effective way of completing the task? So yes, you need to do this, but what is the safest and most effective way to do the task? But always is the question of, do I need to do the task? If you don't need to do the task, no need to even start it. Just avoid doing the task. But again, if you have to do it, then is the question of what is the safest and most effective way of completing the task? Now, the next bit is the individual, which is the I, and the individual capability of completing the task. And by individual capability, we are talking about you as a person. We all differ in morphology, and it's going to be, you need to consider what you've been asked to do. The patient you will be moving, which is the load. How heavy is the patient? Will you be able to move the patient? Have you been trained to perform the task? And it's not about you now. It's a question also, have you trained your participants? So think of, have you trained the people supporting you? So think of the assistants working with you in the hospitals. Think of patient relatives. Have they been trained or have they been aware of how to perform these tasks? Do you have other special circumstances? So, there are tasks that is limited for if you're pregnant, if you have previous injuries. We talked earlier about the implication of you carrying out a task with an injury. So is it something that you have an injury that you can avoid? And what is your clothing? Now, I think for clothing, unsuitable clothing or shoes. Now, I cannot, probably it's just for us to think about it. It's not limited to today's meeting, but I think in certain settings, I'm aware some of us will come or we are doing a patient handling or a manually demanding task. And then sometimes while our outfit is very good for offices where we sit behind the desks, it might not be a good outfit when we go in and engage with patient. So it might be the question of we need to consider our outfit when we are coming to clinics, especially when we're doing certain tasks. One is good to appear very nice, but again, it's good to also look at a suitable outfit that will be able to support the tasks you are performing. Or if it's not you, think of your assistant or think of your whoever is helping you with those tasks. Do they have the suitable outfit to help them carry out the tasks? Talking about clothing, talking about shoes. Are they able to probably just change those outfits if when they're doing to be able to enable them to do the tasks? Do you have enough time? And are you or your colleague able to work? So all these things are your individual capability. So your individual capability is looking at you from how you will be able to carry out the task. And if the answers, if you can't be able to carry out the task due to restrictions of any of those capability, then it's the question of trying to figure out if somebody else will be better suited, or you need extra piece of hand, or you need equipment and things like that. And the load, we are talking about the patient. The load also can be non-patient, but the load we are talking about the patient. If we are talking about the patient, we are talking about their size, their weight, their shape, all those things. But the load can be also not the patient, whatever that is involved. When you are moving the patient, do they have pains? For example, because that will affect the way they help you when doing the task. Are they in a, can they be able to move their limbs? And that will help you. What is the status of their skin condition? I think the nurses here will be the best people to help us assessing the skin condition. But all of us as healthcare practitioners, we should be able to gauge the skin integrity of patients. When they are moving, what is the skin condition? Is it more likely to cause harm to the patient when they are moving? So what is their skin condition? Are they conscious? Will they be able to know when we ask them to do the task? Will they be able to, are they conscious? Are they able to do it or not? Can they balance, bear weight? All those things, do they have attachment? Earlier on, we talked about what are the factors that will influence your risk assessment or affect your manual patient handling. Catheters, IV lines, all those attachments might be one of the things that we might look at in terms of moving the patient. So that's the physical condition, but also we have the psychological condition. The psychological condition is their state of mind or being. And believing you me, in patient handling, sometimes irrespective of the physical ability of the patient, their psychological status can decide even the handling itself not to go ahead, because it has a very big influence on the ability of the patient to do those handling safely or not. And there is no point in putting yourself and the patient at risk when they don't have the psychological state of being to carry out the task. And this is why you look for other alternative means where possible. If you or you try to calm the patient or find an other day where to perform the task. And if it has to be done, then find the most safest way to do it. The environment, we looked at the environment as part of the tile, where the environment can influence the task. Awkward spaces, floor spaces, the temperature, the lighting, the noise in the background, the privacy of the patients, and in the wards. I guess the wards, the clinic, sometimes we don't have influence on how it's been set up, but we can, I think if it's something that we feel is going to influence how we do the handling or patient handling day in, day out, then it's maybe something we can advocate or suggest on how patients are repositioned in beds in wards to allow for accessibility, where us, patient assistant, therapy assistants, or the service users can be able to properly handle those patients. And the last on the tile or the dynamics risk assessment template is the equipment. And for the equipment, I would say it's a question of whether it is even available at the first place. If the equipment is available, then brilliant. Then the question is it have all the safety checks been performed? Have all the safety checks been performed? There are standard safety checks for most equipment, and it's just to make sure that the equipment are safe to be applied to patient. Because the last thing we want is whereby you are applying an equipment to patient with the aim of helping the patient, but it ended up causing more harm to the patient rather than helping the patient. So make sure equipment are great, but it's also the responsibility of the person applying the equipment on a daily basis to make sure that the equipment are safe to be applied to the patient. And if the equipment is there and it's safe to do it, I will always encourage, then use it. But again, is the question, another question is whether we are confident to use those equipment. So that the summary of the dynamic risk assessment tool or framework is the tile. T stands for the task that needs to be performed. I stands for the individual, which is either us or whoever is involved in the management handling of the patient. L stands for the load, which is our patient or non-patient objects. Then E stands for the environment where we function, and then the other E stands for the equipment. And I want us to be consciously applying those things when we are applying those equipment in our day-to-day practice. And talking about equipment, I will sort of bring us to, there are different equipment that we will use in patient handling. There are different equipment that we'll use in patient handling. The first bit is when we are talking about patients in bed. Now, our patients lying in bed, rolling from side to side, we don't want our patient to be in bed. Certainly, the nurses will talk about pressure source. Also, physios will talk about pressure source. But apart from the pressure source, there is also the risk of deconditioning when a patient is just in bed. But again, apart from bed, they will stand up, they need to stand up, or we may need to take them to our therapy and all those movements. So, but just let's say they are in bed and they need to roll, just helping them rolling from side to side. instead of us using our energy to pull them from side to side, is there any way we can enable them to try to help us move from side to side or move up and down? Now, one of the equipment is the bed levers, which is being shown on the picture. Now, the bed levers is just an equipment which we can attach at the end of the bed of the patient on both sides. We can attach it on the left and the right and the top side where they can use it with their hands. So think of your patient just rolling, reaching out with the opposite hand, and then pulling themselves if they have the upper limb strength to roll while with or without your support to one side or the opposite side. And we can use the rest of the principle where we ask them to bend their legs and then roll towards, push through their legs and roll. So these are equipment that helps the patient in rolling in bed. And all the 2-hourly turning that we do, for example, if a patient is bedbound and we have to turn them every 2 hours, this will now reduce the likelihood of repeated actions whereby the patient will just pull, roll to one side, and then we do our positioning, put the pillows and everything. Or if we want to do personal care, we clean the patient, and then once they finished, they roll back without us pulling. So that's good way of minimizing the risks to people involved in supporting the patient, as well as for the patient also is good for them for their function and ability. But also we have transferring to up and down the bed. If we are patients, sometimes in bed, patients might sleep or might find themselves in an awkward posture, and we need to reposition them. So repositioning the patient is trying to make sure that they are in the most comfortable position. I have seen a practice where we sometimes is dragging the patients by hand, pulling them on from their shoulder, or trying to pull the bed sheets. Now, there are probably, I said, better ways that we can do that, and it's by use of the slide sheet. Now, the slide sheet is the next one under the bed levers that is being displayed and the use of the equipment. The slide sheet is a slippery, just think of any slippery, non-sticky sheets that once we put it between the patient's body and the bed, it gives us that, it takes away the friction that the patient will have when they are moving in bed. So by putting those slide sheets, and there are different types of slide sheets. There is the tubular one. There is the one that you, the two ones that you put it on top of each other. But the whole idea is the slide sheet will roll on itself, and it gives that smooth movement for the patient. And it makes it less, it reduces that sheared force that will either cause damage to the skin or make you or the patients to put more effort when doing the movement. And you can use those slide sheets to pull the patients up or down the bed, to reposition them in the bed, or to move the patient from one side to the other. Remember, we talked about in terms of one of the risks of injury is bending to reach for the patient to pull them. So you can use the slide sheet to just transfer the patient closer to you instead of you bending. And with the slide sheets, it doesn't have to be all these factory-made standard grade slide sheets. Think of any slippery material. I think we have them in abundance in your clinic. And I think if you are handling patients in hospitals, I will say slide sheet is one of the biggest things that you probably should look for or have, whereby it's easier for you to use. It makes your life and the life of your staff or the life of whoever is handling the patients more stress-free. Think of any clothing material that is very silk, very slippery, and then you do it one on top of the other, and then you can use it. But when using the slide sheets, I think one of the risk factors that we need to be aware of is whenever you put it on the patient, because it's very, very slippery, you do not want to leave it on the patient. So you need to be mindful, because if not, if you leave the patient, it might slide off the patient off the bed, or but instead of helping the patient, it can cause injury. And the bed leavers as well, we need to be mindful of the type of patient we use them, because if we leave the bed leavers, because we are putting it at the end of the bed, the patient can get stuck in between them, or their arms can get stuck in between them. So these are probably, I would say, some of the equipment we can use in repositioning the patients in bed, whatever position we want to put them, using equipment. And of course, we can use our strength. In the absence of equipment, then is where our techniques will come in. We will look at some of those we will talk about those techniques, our techniques of rolling the patient using our own natural body strength. But when we are rolling the patient without equipment, then it's the question of applying all those biomechanical principles of making sure that we do not injure ourselves. We do not injure ourselves. I will probably pause here and invite. So talking about maneuvering the patient, before we talk about using techniques or using our natural body mechanics to move a patient in the absence of techniques. But let's say we have equipment, or maybe not equipment, but my question is, what type of patient do you think they will need this type of transfer, whereby we move them from side to side, roll them up and down, and then they will need either using the slide sheets? Just thinking about your practice, what type of patient do you think will benefit from a slide sheet or will benefit from a bed lever from your practice? Okay. And I probably said this one is best if we unmute a mic, but again, if you can't, if you're in a busy environment, then it's okay for you to use the chat function. But it's best if we sort of have a conversation and explore it a bit further. So thank you, Abdul. I think Abdul mentioned about stroke patients. But I want a bit more. What type of patient? So stroke patient varied on a spectrum. You can have stroke patients who are able to walk or even run, or you can have stroke patients who might not be able to walk. So I don't think Abdul, might not is referring to stroke patient that can be able to mobilize themselves. Okay.
So can I say quadriplegic patients?
Okay. When quadriplegic patient, okay. And how will they, okay, 4 limbs not moving, okay. Suleiman mentioned quadriplegic patient. Yes, quadriplegic patient. But the question is, Suleiman, which one? Is it the bed levers or the slide sheet?
The slide sheet, sir.
Okay. And why permit me, I usually ask a lot of why. Why the slide sheet?
Usually in terms, just as you explained, in terms of rolling them or trying to sit them out of bed. So if they are too heavy, so it will be easier for you to use the slide sheets to draw them closer to the bed edge. Yes, sir.
Yeah, thank you so much. Yes, quadriplegic patient, because it takes away that friction. And so by quadriplegic, they don't have the use of a perfect example of patient. And I think anybody else, what type of patient do you think will benefit from any of this from your clinic?
Unconscious patients.
Okay. Unconscious patients. Okay. Do you want to, how will they benefit from it? Which one is it, bed levers or slide sheets? Thank you.
They will benefit from the slide sheets.
Okay. Yeah.
Yes,
Okay, thank you.
because I think in terms of affordability, it will be more easier to assess than the bed liver here.
Yeah, okay. And just permit me, thank you so much for the contribution. In the absence of the slideshow, what alternative is being used at the moment?
For now, we use pillows. Sometimes we roll sheets or towels.
Okay.
Using our strength, yes, we use our strength to move the patient, roll
Okay.
them, and support them with pillows or towels.
Okay. Yeah. Okay. Thank you. And not necessarily there is anything wrong with what we're doing. It's just the resource limitation. And yes, we can use pillows, roll them, but again, that's when we come to using our strength and how we can use it efficiently. When we're using the pillows, bedsheet, we need to be mindful of how to use it so that we don't injure ourselves. But yes, that's another perfect example. Unconscious patients, quadriplegic patients. Any more examples? And I think people mentioned about in the chat box, bariatric patients. Yes, that's interesting. Why bariatric patients? Roxana, if you be able to expand on it, mute yourself. And what do you mean by bariatric patient? Because just want to understand a bit more.
Hello, everyone. Good morning.
Yeah, morning.
So what I mean by bariatric patients is patients that are on the heavy side, that's they've got weight.
Okay.
So we can use slide sheets to help them roll from side to side.
Okay.
It would definitely have to be 2 people.
Okay.
One
And why?
on each side of the bed.
Okay.
And bed lever. The bed lever is mostly attached to it is attached to the side of the bed, so the bariatric patient can hold on the bed lever as an anchor to help pull themselves either up or down the bed. So it's another method of the patients engaging with you during therapy sessions.
Okay. And is it only well part of the therapy session? Yeah. Brilliant. Thank you. Yeah. Yeah.
Thank you.
Carry on. Okay.
Hello?
Yeah, I'm here. Carry on.
Oh, yes. Sorry, you asked a question.
Oh, yes. I know you mentioned therapy session. What I want to say is it only therapy session?
Okay, no, it's not only therapy sessions. Generally the bed lever is supposed to be kept, or should I say attached to the patient's bed, so it can be left, not just for therapy patients, for general use on the wards.
Yeah.
So I'm talking of typical ward setting. So not just only for therapy sessions. Nurses can also benefit from that, because a patient has a bed lever. So say they want to check some dressings, they can hold on the bed lever, the patients adjust themselves in the bed and be more comfortable.
Thank you. Wow, that's another brilliant example. So with the bariatric patient, or with the example explanation that Roxana have given, that takes away that repetitive actions whereby we have to sort of do it over and over for the patients. With the patient doing it, it makes it easier for all of us to do our job, really. That's good. And I think also spinal patient, Abdullah mentioned spinal patient, absolutely. TBI, yes, absolutely. So there are quite few patients, unconscious patient people mention. So yes, there are quite a lot of people that will benefit from this equipment. And like I said, for the slide sheet, it will be ideal. But again, if we don't have a slide sheet, then we can use other sheets that we can use for our patient. Bed sheets, people use bed sheets. Pillows was given as an towels were given as an examples. But also they can find any slippery objects that can be used. The bed levers, ideally, we have bed levers, put it on the bed sides of the patient. And I would say sometimes this equipment, you don't have to keep it in the hospitals. It doesn't have to stay within the hospitals. For those of us that are doing private practice in patient homes, or for those of us that are doing community physio, or for those of us that have patients that are outpatients that are heavily dependent, that they are wheeled back into our outpatient clinic. These are recommendations we could possibly give to the patient, relatives, families, or even as an equipment tool for us. Not, of course, the bed levers, but again, we can have it. But the slide sheet, when you go to your community practice, you can use this or you can encourage the patients to have this to be used with their relatives. It doesn't have to be with the therapist. During the therapy session, we can use it with their relatives at home, or we can leave it in the ward where whoever healthcare workers, the nurses for the dressing, we can use it with the patient. In the absence of the bed levers, and this is just to say we can be ingenious by asking the patient, because the whole concept of the bed lever is for the patient to find an anchor and leverage on it and pull themselves. Think of any anchor that the patient might have that is very stable, very strong in bed. Some beds have bed rails. You can use those bed rails for the patient to pull. Some beds have handles. You can ask the patient to, if they can, to pull those bits, even in the absence of the bed levers. But let's say in the absence that the patient, we don't have the luxury of slide sheets, and we don't have the luxury of bed levers, and we still want to move the patient from side to side. What are the alternatives? I guess people use it differently in terms of using our muscular strength, but one of the efficient way, if you are looking at moving and handling, and of course it depends on the patient ability, one of the efficient way of doing it is, if it happens that you have to use your strength to do it, is first is if a patient is lying in bed, supine, facing off the ceiling, is trying to, if possible, and I know it's the question of possibility, the bed that the patient is lying down, trying to lift it to your waist height. Trying to lift the bed or pump the bed to your waist height. That's the first step. Trying to lift the bed to your waist height, so that when you are helping move the patient using your strength, you are not bending over. We talked about the implication of bending over on our back. So trying to pump the bed to your waist height, if it is possible. Whether it's electric or manual, just lift it to your waist height. If two people are going to be involved in bending or moving the patient, it is advisable to use the height of the person that is shorter, if it's the right word. That is not that is the height of the person that is of less height. Because the person, what you don't want is when two people are lifting, you don't want the person of the left height to be tiptoeing, because that displaces their base of support and puts strain a lot on their selves. What alternative it can be is the use of the, while the person of the higher height can be able to bend and then use their lower limb strength. can be able to bend to adjust their height. So first, lift the bed to a comfortable height around your waist. Second, all we are thinking of preventing injury to yourself, move closer to the bed. So try to reduce the lever arm, so the length of the hand that you will be stretching to pull the patient. Try to reduce the lever arm, both if you are using one person maneuver or two people. Now, once you are close to the patient, you need to decide if you're able to move the patient or not. Of course, we've talked about this previously, but let's say you're able to move the patient and you're going to move the patient manually. The third is try to see if the patient can be able to help you. And how you do that is by asking the patient, first is if the patient can be able to bend one of his legs. So if you are moving the patient, for example, towards you, and the patient is moving and you are standing on the right-hand side of the patient, then you lift the opposite leg of the patient on the left-hand side to serve as a leverage where the patient can push through the bed and then roll towards your side. Push through the bed and roll towards your side. So bending the leg opposite to where you are standing, the patient, and then ask the patient to use the opposite hand of the hand opposite to where you are standing to pull it across to you, and then take away their hands. It depends on their injury. Try, if it's a stroke patient, of course, try to avoid them putting weight on the affected hand. And then once the patient is able to do that, legs bend, opposite leg bend, opposite hand pull across to where you are. Now their body is already tilted towards you. And if it is a one person's lift, you can rock your legs and use one of your hands across the hand on the upper part across the pectoral girdle, and the other hand across the pelvic girdle, and just try to roll with the patient helping you, rolling towards you. If it's a two persons lift, then the person opposite side can then help push while you roll towards you. And that reduces the amount of effort you will pull the patient or strain the patient. Now, I know it's very difficult. I'm trying to explain things that are quite very abstract, but we will be doing the practical training in next week, which I'll talk at the end of today's session. But the whole idea is try to find an efficient way of pulling or pushing to minimize the risk to you and to the patient. I understand sometimes some of those processes is we want to do things quickly, just get it done with. Let's just get it done with, but it might lead to more injury. So try to follow the process, do it smoothly, and the more you do it, the better it becomes. So that is and then that will be able to roll the patient to one side and then finish what you want to do, and you can now do the opposite side and roll the patient to the opposite side. And in the chat box, thank you, Roxana have added another object that we can use it in terms of the patient to hold it and pull themselves. It's another equipment, if it's that possibility that we have the luxury of equipment for the equipment to be used. But apart from what I've said, in terms of, so that's the rolling, if we are going to use our manual strength to pull a patient. Now, what if you're going to do a sit-to-sit? Yes, I think somebody has a question, and I think I want to, yeah. So before we move on, any question on using our manual strength to pull the patient? Yes, please, Suleiman.
Hello, sir.
Yes, I'm here.
Yes, sorry to interfere.
No, don't be sorry, yeah.
Thank you very much, sir. With respect to faulty beds, this is more like a practical question. I used to do it, but I just want to confirm whether I'm right or wrong. In case of faulty beds, that the bed are not adjustable. So, and I want to do some bed exercises on my patients. So what I used to do is I sit down on a plastic chair by the side of the patient, carry out my exercise in that position.
Okay.
So how do you see this?
Okay, that's a very good question. And in fact, it has generates other sort of things that I probably could have added on this conversation. But that's a good question. So maybe I'll throw the question back to the class. So we've had the question, what do people think of this approach? Considering all the principles we've discussed, what are the good or not so good, if there are any, or things to consider? Anybody, please. But that's a very excellent, very good question. What do people think about this approach? If anybody wants to comment on it, please. Okay. So in terms of this approach, first is just to mention, it's good that you have considered lowering yourself. I believe there is a rationale why you did not stand up and you are doing your exercises. You've considered one of the principles of avoid bending. So that is one good thing. You've lowered yourself in terms of faulty bed. So that's a good principle. And secondly, the lower you are to we reduce the length of line of gravity, it's more stable you are, all those things. Sitting down on a plastic chair to do the exercise. What I would say is how you sit down, okay? How you sit down. And what I mean is that when you're moving, when you sit and you are twisting, did you sit? If you sit and you are facing the bed and when you're doing your exercises, you minimize or avoid twisting, then it's good. So it's good when you sit and minimize the twisting, then I think it's a good approach that whereby you are preventing your back. But when it involves you are facing one direction and you are twisting, then it's another thing that you might want to consider to improve on that. And I think Roxana also added a comment on the chart function, the distance between the patient. Again, if you sit on the plastic chair, and again, some of these things that are practical, there are things, there is how much we can do. It's not an ideal world where sometimes you cannot move further to the distance. It's just for you to be aware. So yes, it's a good approach in the limited resources you have, but the second bit is the twisting. If you're sitting facing the patient, maybe that will reduce the twisting. But if you are sitting, especially when you're doing handling, but if you are sitting facing one direction, up or down, it depends on what you're doing. It might require you to be twisting, and that will increase the strain on your back. That is for you. Then for the patient also, depending on the exercise you're doing, you may want to ask the patient to move a bit closer to you to reduce the distance if the patient can. If they cannot, then you have to make do with it. But if they can, then you reduce the distance to the way you are sitting to the patient. But I think overall, it's a good start approach, Suleiman. So that's good.
Thank you very much, sir.
Comment. Yeah.
Sorry, sir. Finally, again, how do you look at gender difference as a psychological component in terms of the load, that is the patients, in the previous slide we mentioned?
So in terms of psychological difference or physical difference?
No, psychological difference.
Like in terms
of opposite gender trying to lift a patient.
Oh,
can
okay.
That yes.
So in terms of the gender difference, now the reality is we are serving what patient-centered care is means that we try as much as possible to support the patient. We are there for the patient, and we take into cognizance their cultural and religious and other preferences. Generally, we take that into account. Irrespective of how best we want to deliver things, sometimes we have to take into consideration the context at which we operate, and we have to respect those bits, and we find ways to operate them. In patient handling, and especially in situations where we have limited resources, it will involve you using your hands a lot on the opposite gender. And I think that is another sensitive area in patient handling. And in the situation where there are no options, then it's a discretion of conversation, trying to explain to the patient what you're doing, because it will have an impact on how they feel when they are doing these things, their involvement. So explaining to them the processes, what you will be doing, and where you will be placing your hands and the involvement of it, it's quite very important to just reassure them that you are just being professional and this is what you're doing. So I think it's very, very important to get their consents of all handling, to explain what you are doing, to explain the benefits of what you're doing, and to gain their consent after you explain it. Without their consent, you cannot proceed. However, if there are alternatives of, instead of the opposite gender carrying out the handling on the other gender, and if there are alternatives, because I know sometimes policies and hospitals policies might just, you are in the hospital, irrespective of the gender, that is the person that will see you. Okay, sometimes the hospital policy will detect whether there is even consideration for gender differences. But if there is alternative for you to have the gender of same gender, then it might be most appropriate and most convenient for the person doing the handling to carry out the handling. But we all know that that sometimes is very difficult. You have a caseload to handle, and then that is what you will do. So in the case where there are no options, I would say you need to reassure your patient and explain your rationale. And I think most people will be able to go along if you have explained your rationale, explain the benefits, explain what you're doing to carry out those handling, hand placements and things like that. And remember, with the handling, where possible, you only need to use your hand only if the patient cannot do it. So your handling, patient handling sometimes might mean that you giving instructions and just using equipment and everything, trying to enable the patient to carry out the transfers. It has an impact. In summary, it has an impact, but again, it's just the process at which you carried out your tasks that will have that influence, that will detect for you. Bottom line, if the patient said no, there is nothing you can do to proceed. Their consent is always important for you to proceed. But if they are happy and then you explain to them what you're doing, then you can proceed. I hope I've answered your question, Suleiman, if I understand the question.
Exactly.
Okay. Any sort of question just on this patient bed-to-bed maneuvers before we proceed? Okay. Just to mention also, Suleiman have raised a bit of a question for me. So when you're doing the manual handling on your hands, or when you're doing it physically, when you're doing it with the slide sheet, rather, just to roll back a bit, when the direction of how you use the slide sheet matters, your foot placement on when you're moving the patient matters. What I mean is that when you put the slide sheet on the patient and you want to use the slide sheets to maneuver the patient, it's best if you move, if you are going to face, if you are not moving your legs, stepping forward and backward, to face the direction of the slide, the movement that you are performing, so that you are rocking forward and backward. Or if you are facing the patient, you just take a step forward and backward. That you avoid twisting your back or bending too much. So all those things matters. But we will consider it in the practical sessions. But just for those who can't make the practical session, the direction of movement of the slide sheets matters when you are moving the patient. Now, if, for example, a patient are medically stable, seat-to-seat maneuvers rather, if we are going to move a patient from one seat to the other, that is the seat-to-seat maneuver, we don't have to necessarily pull the patient, and it depends on their ability, really. Of course, if patient can be able to move on their own, fine and good. But if they can't necessarily move, maybe the patient just can be able to sit at the edge of the bed, and then on their own, they will not be able to stand up, move, or transverse. Then in terms of handling, there are equipments that can help us in terms of transferring patients from their bed to the chair or from the chair to the bed. The first one is the red one, which is it's called a return. Now, the return is very nice, beautiful piece of equipment that is very stable. All the patient needs to do is put their feet on the plates on the floor, and their knees, the two parts at the halfway to the equipment is where the patient will put their knees in between on it. And those parts can move up and down depending on the height of the patient. You can move the parts up and down. Once your patient is sitting at the edge of the bed, all you need to ask them is to reach for those bar rails at the top, and they can pull themselves. So in this situation, it is possible you don't even have to use your hand pulling the patient, just the patient pulling themselves and then bringing themselves to a standing position. And once they are in standing position, you can just turn, so the disc plate on the floor can turn itself left or right. You just roll it, and then you put the patient in the wheelchair, and then you take them to either your clinic if you want to do, or your assistant takes them to your clinic if they want to do your rehab, or the nurses if they want to take them to wherever they want to go. You just roll them and put them into that bit without pulling them. And then once they finished whatever, and you bring them back in the wheelchair, if they cannot stand up, they just do the same process and roll them up. But for patients to be able to use the return, we are talking about patients who have ability to stand on, they have good leg strength. They don't necessarily have to have the brilliant leg strength. If they have 2 to 3 leg strength, muscle strength, so 2 to 3, I mean, for the physios might know, for the other might not or may not. I'm talking about Oxford muscle grading scale. If they have a bit of muscle strength on the limb, they can stand on it because the part in between will prevent the knee buckling. And even if your patient is a bit more dependent, the right object have a bit of what we harness or a belt that you can use. So some of them have belt to secure them if a patient have difficulty to stand for a long period of time while you do your maneuvers. So that's another good piece of equipment that you can use to enable a patient to stand up from the bed to the wheelchair or to the chair, or you want to transfer the patient from the chair to another chair. But again, it has to be an appropriate patient to use this type of equipment, which we'll talk about it. The next one, apart from the red equipment, the next one is the red equipment is called return, RETURN. Or there are other modifications of it that are called patient turner. So it's basically a patient turner, taking away that manual labor from us. Now, apart from the return, and it's been spelled, the R is capital, the E is small, the T is capital, then U is small letter, R is small letter, N is small letter. Or the other variations is the patient turner, which all of them do the same function. In our face-to-face practical, we will try as much as possible to use some of those equipment. We will use the slide sheet. We have the bed levers as well. So in the practical that will be happening in 2 weeks' time, we will have this equipment to practice with them. And we will have a variation of the red one as well to use it for the practice. Apart from the red one, we have the blue color? It is called a Serra Steady. Now, that also is another piece of equipment you can use for transferring patient. Now, the Serra Steady, it's quite very stable. And compared to the red one, the Serra Steady is for patients who are less able to stand on their feet, and they need a bit more support. But they can sort of stand up, but they cannot stand up necessarily for a long time on their legs, or they are a bit unstable, unpredictable. And the same principle that you do for the patient, the return or patient turner, is you bring the patient, you position them at the edge of the bed, which is a different manual handling process, and you put their foot placement on the plate down, and then the blue foam in between, it's used to stop their knees from translating excessive forward translation, and they can nicely place their knees on that foam. And then the other blue bits that is right on top, you fold it out so it can open up, and then the patient will stand up and stand right in between those barriers. And then once they are in a standing position, you push back the seats. So the two blue bits at the top, they are seats for the patient for different gluteal area, where they can put it back. Once they are up, you put it back and they sit down. And then you can now move the patient from the bed to the chair, or from the chair to the bed, from one position or the other. Both the red one and this blue one, the Serra Steady, are not meant for transportation of the patient. They are meant for transferring the patient over a short distance from one platform to the other, ideally. Although people use it differently, but ideally it's not meant for transferring the patient. It's meant for transporting the patient. And just to ask, I think before we come to the manual transfer, the thinking of your clinic, what type of patient do we, and you can put it on the chat box, what type of patient do you think might benefit from these two pieces of equipment, irrespective of what you're doing now? So either the red one or the blue one, both of them do the same bit. What type of patient do you think might benefit from using these sort of pieces of equipment? So if you are profiling a patient, okay, spinal cord injured patient, okay, spinal cord patient. Okay, we'll talk about it. Just what type of patient? People can add a bit more. So thank you, Suleiman, for adding that, but we'll talk about that. Spinal cord injured patient, stroke patient. Okay, thank you, Mr. Ibrahim, for stroke patient. We'll talk about that again. What type of patient? While people are still adding, I'll come back to the chat. So spinal cord patient, do you mind, Suleiman, do you want to expand? Because I'm just thinking, is it complete spinal cord, partial spinal cord? What type of, because I'm mindful, what level of ability do they have that they can use this?
So incomplete spinal cord injury, especially at the thoracic region, where the problem is more on the two lower limbs and the upper limbs are stepped.
Okay, that makes sense. Okay, yeah, they can use that in terms of bringing them into a standing position. But again, the incomplete, we need the lower limb supported. But they are brilliant. That's an example. Stroke patient, Mr. Brown, if you are happy, do you mind expanding on what type of stroke patient and why will you use that for them? Or anybody really? But okay, stroke patient, yes, we can use it for stroke patient, but it all depends on the type of stroke patients that we're using it. Those that are able, those that have more ability, of course, there is no need for us to sort of use it for them. Now, apart from using the pieces of equipment, we can certainly move our patients by doing what we call manually handling the patient, where we support them to stand up and to move them from the bed to the chair or from chair to bed using our physical abilities. And how we do that is we use our manual handling techniques. I think probably it's best if we practice it because I'm mindful of my explanation. But again, we can use it manually. The same thing in terms of when we're trying to transport the patient, you can do a sit step around transfers or pivot transfers. There are different transfers we can do it, which we tend to do in our clinic. But irrespective of the transfers we are doing, is one, we encourage the patient to do it as much as possible. Two, we consider our foot placement where we stand as well as the patient where they stand, and try to avoid bending, twisting, turning when we are moving the patient from one seat to the other. Another one I did not put on my PowerPoint is because they mentioned spinal cord, is the banana board. Now, the banana board is another good piece of equipment that we can use to transfer patients, especially whether they have complete spinal cord or they have problems with their lower limb, or sliding board. Banana board or sliding board. We can use that banana board or sliding board to transfer patients from one seat to the other or from one bed to the other. I've just put the banana board on the chat box. And we will have this also to practice on our face-to-face. With the banana board, it's mainly used for spinal cord patients, but you can use it for all type of patients that fit into this criteria. And one good thing about banana board is it promotes the independence of especially spinal cord patients, whereby if they are going to continue their life for a long period of time, you can train them on how to use this banana board, and they can continue to use it independently without your own help. And the same thing, apart from seat-to-seat maneuvers, I think we can certainly use this sort of equipment to do it for the standing. We've discussed the standing bit earlier on. Now, in the absence of, now it depends on the ability of the patient. It depends on how dependent they are. It depends on whether they will be able to help us or not. If the patients cannot be able to help us, if the patient is very dependent, then it's either we avoid or we try to use what we call a hoist. And a hoist is a fantastic piece of equipment, I would say, that helps transporting especially manually heavy patients. In certain society, I think there are a situation where you have to bring 4 people to move a patient. Whereby you have to bring a lot of people to move a patient. Hoist takes away all those headaches and make it easier for us to use the patient. And hoist is predominantly used for patients who have significantly reduced ability, strength, who can't help in doing most of those tasks. And there are different type of hoist, I would say. We have the standing hoist, which is the one in the picture. where you can use it either in your outpatient clinic, patient can use it in their house, which if they can afford. You can use it in the ward. So a ward doesn't necessarily have to have a single hoist every ward, but you can if it is a fortune, if you have the finances to do it. But a standing hoist, the advantage is wherever you have that type of patient that needs to be transported, you can just roll that hoist to that particular place and then use it for the patient. For the standing hoist. Alternatively, some practices usually have this type of patient in a specific wards and you can use it for them. Now, apart from the standing hoist, there is also the ceiling hoist. There is also the ceiling hoist, whereby you fixed it on the wall, on the ceiling, and then it's fixed. Usually is meant for patients' home or maybe in a rigid location, but I probably said mostly in our practice, maybe most of us might come across the mobile hoist. And the mobile hoist is another equipment that we will demonstrate in our practical that we'll be doing in Nigeria. But for those that I'm probably not be able to attend, just to mention, the mobile hoist is, in terms of the application of the hoist, is for highly dependent patients. And the hoist have different slings. The hoist have different slings. Now, the slings, so apart from the mental frame, which is the hoist, we have the slings, which are where the patient is sitting on it. Depending on the patient size, you choose the appropriate slings. Now, the slings measurement, how you measure the sling or how you decide on the size of the sling to use for a patient. Yes, we can use our eyes. Just by looking at it, you can decide, oh, there is usually a small, medium, or large, and you will know in terms of this will fit to the patient. But apart from the size of by looking at it, you can use, there is a way you take the coccyx of the patient as one of your landmarks, and then you go all the way to the cervical bones of the patient, and you hold the slings and you measure it from the cervical to the coccyx. If the sling covers all that region, then yes, it is appropriate for the patient. What you don't want is that the sling to be too big for the patient and then the patient will just fall inside the sling, or the sling to be too tight for the patient, which will just strain the patient's body. For the hoist. And may I ask if there are people that have used the hoist before in their practice? Anybody have had experience of using the hoist? And my next question is the type of patient they've used it for, and what are the safety checks they use before they apply the hoist? Anybody have had the experience of using hoists in their practice? Okay. So yeah, so I know it's some of those equipment can possibly be a luxury, but hoist is one of the, you use it for highly dependent patients. And in terms of safety checks, you check for so starting from the sling, because the sling is a piece of cloth, you have to check that there are no wear and tear, because the last thing you want is a patient that is hanging suspended in the air, and then the rope or the slings will just tear, or it will give way and your patient will come crashing down. So one of the safety checks you always have to do if you happen to come across slings is you check that there are no wear and tear on the slings itself. And on the machine itself, in different countries have it differently. There is usually a checks that is usually being done. So make sure that it's been checked mechanically, that there's any mechanical or electric fault, because it's an electrical device. Some of them use batteries. Some of them are manual. If it's battery, you have to make sure that the battery is working. And the emergency safety button, there is usually an emergency safety button that will bring the patient down immediately when there is any problem without going through the remote control. And when you're moving the patient in hoist, is you try to, usually it's two people that will use it. And in terms of when you're moving the patient in hoist, usually are two people that will move the patient. It's good also for patients usually that falls patients that are usually falling and they can't get up on the floor by themselves. It's another good piece of equipment that we can use it for. Helping the patient to stand up. Now, when our patients are on the floor, yes, of course, if they will be able to stand up. When our patients are on the floor.
Do you have anybody? Because I'm saying this because everything on the stop, everything lie.
When our patients are on the floor, if they can stand up, we will encourage them to stand up. But if they cannot stand up, there are I've muted myself. I've mistakenly muted myself. Yeah, okay. Yeah, back. So when our patients are on the floor, the first bit is whether they can stand up by themselves. That's the first thing. If they can stand up by themselves. If they cannot stand up by themselves, then is a question of how can we help them to stand up. There are different processes or protocol in different societies. Certainly in UK, there are protocols to follow for any patient that has fallen. But in the society, I guess in low resource setting or in other societies where in Nigeria in particular, when it's difficult to get the patient up from the floor, this is standing. Well, maybe I want to talk. Oh, this is for standing patients. So this for standing patient, from sitting down is basically the sit to stand practice. When we are standing patients in terms of manual handling, sit to stand practice. And in sit to stand practice, the main thing that we need to consider is foot placements. There is usually preparations that you will do before a patient stands up. First is foot placement, making sure that their foot is placed appropriately. We talked about the impact of the base of support to our balance. So we want their foot to be shoulder width apart. And where possible, we want their feet to be slightly bent underneath their body. We want the patient to displace their center of gravity forward. That will allow them to stand up. So these are all the things preparation will do when we want to stand up. And we give them instructions. For us as therapists, when we are standing or whoever is supporting the patient, you want to stand in the direction of the movement. You don't want to be twisting. And then you want to support them. If you have to support them, one arm should be around their lower lumbar region, just to give them that slight notch if you have to do. The other arm should be around their shoulder in front, just to prevent them from excessively moving forward. And you give good instructions and you transfer them from sitting to standing position. And now this is the one I was trying to talk earlier on. If your patient has fallen on the floor, and they have to stand up, there are different countries have different protocol in standing patient from the floor. But one of the things that I highlight is you will have to follow your local policies or whatever it is that is been established. But one of the practice that I can highlight is there is what we call backward chaining. Backward chaining is whereby you enable the patient to stand up, either using their own ability or you support them when they are trying to stand up if they cannot stand up from themselves. And with backward chaining, it's all about, so for example, if a patient has fallen down, irrespective of the position, what you want to do with backward chaining is to make them to lie down supine. And then from supine, they can roll the same rolling technique we discussed earlier on. They roll to one side. And then from the one side, you ask them to go into a 4-point kneeling. And then from the 4-point kneeling, at this position, you bring a chair close to them where they can do into 2-point kneeling and using their hand to support themselves on the chair. And then you bring another chair or somebody bring another chair behind them. And then once they put to have one using one of their legs and then pushing themselves up, they don't have to come all the way to standing. They can sit back into the chair, or they can, if there is only one chair, they can do from that one leg in the bend, flexing one of their knees while the other one is in the bent position. They cannot turn and then sit down. Or alternatively, to make it easy, if it's a luxury, using hoist to stand them up from the floor. That's a lot of talking. I will pause here maybe and ask if there's any questions. I know it's a lot of description, but hopefully the demonstration will be far better than the talking. Is there any question or any clarification anybody wants to ask? And maybe let me ask first, how do people deal with a patient who has fallen? How do they get them up from the floor? How do we do it? Is it the same with what I did, or is there anything anybody wants to add on getting patient off from the floor?
Hello, sir. Can I talk?
Yes, you can talk, sir.
Thank you very much, sir. I think from my own experience, in fact, I'm really excited with this maneuver that you brought up, because this is how I currently have a patient like that. And I was lucky to progress him to be able to stand up just through this process that you mentioned, with a cushion chair by his side. And since then, he has been able to get up. Whenever he falls down, he can maneuver himself close to the cushion chair and then get up with the support of the cushion chair, moving into 4 points, then to 2 points, and then getting up. So I'm happy for that. And I just want to say here that with this level of achievement, should I still struggle to see that he becomes more independent by standing without supporting the chair?
That's an excellent question. Now, first of all, is well done for doing that, because one of the whole idea of backward chaining is to enable the patients to do it themselves. While you can try to do it with them, but it's the enablement. I think that's what I really like with what you said, he is able to do it by themselves. That is the whole point of us intervening. And most of the patients that has fallen, because there is that risk, higher risk for them to fall again. What you don't want is that for them to fall, get stuck in the floor, and then nobody to help them, and then it become a problem for them. What you want to empower any patient that has fallen before is ability for them to stand up again, if they can. So any patient that has a risk of falling, or they have fallen before, as a clinician, what you need to think of is how they can stand up, empower them, which is what you've just described. And backward chaining is one of the examples. Now, the second thing is, should you progress them to do it independently? The straightforward answer is absolutely yes, if you can. Absolutely yes, if the patient is in your clinic, if the patient is what do you call it? It's somebody that keeps coming back to your clinic and they have the ability to do it. Yes, do progress them. However, just to highlight, sometimes some patients need just the strategy to cope only with their day-to-day life. They might not be able, they might, irrespective of the progression, when they fall down, they probably will 100% still need that support to stand up. So if they might not be able to do it independently without support. But yes, if you can, if they have the still ability to progress, I didn't know the profile of your patient, but yes, it is something that I will encourage you to practice more with him. Identify those parts of the muscle strength or strategies that he can work on to improve on that. But that's an excellent question. Yes, brilliant. Thank you. I hope I answer your question, Suleiman.
Exactly, sir. Thank you very much.
All right. What do people do when a patient falls? Is there anything else people want us to add? I know it's almost, well, for our brother and sister, our fasting is different, but other people is almost lunchtime. We are almost 40, 50 minutes away from finishing today. So I want to hear your voices. I've been talking. While I'm still want to hear your voices, I'm just going to bring us this bit. Some of the handling techniques that probably some of us are culprits or some of us are not, but just to bring it up. So patient handling, what do people think about the pictures I'm seeing here? Okay, maybe the picture is not too clear. I'm going to put it on the chat box. And sorry too, I think somebody mentioned that they've been kicked out and they are trying to get back and something like that. What do people think of the picture? Sorry to Omodara. I think, I hope you can hear me now, because I think most people can. If not, try to rejoin, please. What do people think? What do you think of these techniques when you see these techniques? Is this something we tend to do in practice? And if it is yes, what is the implication to us and to patient? And what are possibly, is there anything we could do differently? Oh, okay. So what do people think of these techniques? We have different techniques on the PowerPoint. Is it something people we tend to use or not use? And do we have an alternative to it? While we're still thinking, I really want to hear a comment. If there are nurses in the platform, how do you maneuver patients? Well, everybody really, not necessarily nurses, but I know the nurses also are always involved in maneuvering patients. So how do you maneuver patients in, is this something familiar with you? These techniques on the point and, okay. Yes, somebody, Yunus mentioned yes, and they do it most times. Yep.
Hello.
Yes, I'm here. Yes, hello.
I think most of what diagrams we have here, most especially in a low and middle income environment that we have, that is what we are comfortable with, where there is less of instrumentation involved in maneuvering patients. Most of these things are what, well, for example, in Nigeria now, most of these things are what we are conversant with. Only that based on what we are learning today, if we can, what we need to just put in our approach, our technique, in a way so that we won't harm ourselves and also harm our patients. Like for example, the bear hug and the pivot transfer is what we are conversant with and we use most often. And same with others. But the only thing that we need to add to it now is to put in the proper ergonomics of our body, and so that we will not be able to, for example, the person that is doing the bear hug here, good enough, the person is closer to the patient, is not actually reaching. So, and what the person will just need to do is to have a good base of support.
Okay.
So that at the end of the day, and using the avoiding too much of twisting.
Yeah.
So that the therapist or the handler will not injure himself or herself, while also not injuring the patient in the process. But when we have instrumentation, like the hoist that we talked about, if the patient is on the heavier side, then we know that we should be able to utilize those instrumentation. And the third picture, we see evidence of reaching out there, even though the handler, one of the handlers, tried to maintain a wide base of support. But there is a little bit of bending because it's not closer to the patient enough, like what we saw in the bear hug posture. So the orthodox lifts, and what we have learned today, at least if we have materials that can be used instead of the usual orthodox, what we do that most often in our side here, in our climb here, we do that. But from the exposure that we are getting, we can, like you said, during the lecture, that we can get anything that is slippery, not necessarily the material that is the material that, but if you can improvise, improvisation can come in, so that will help us from the reaching out that the people are, and bending, that serious bending that the handlers are doing here. And again, the height of the bed is low.
Yeah.
So that should also be put into consideration, that the height of the proper ergonomics of the height of the bed to the handlers and to the patients. So that's the same thing for the drag lifts. Instead of the drag lift, we do that here, but we can improvise and help ourselves and help our patients to improve on the way we handle. The Australian lift is killing. It's not something that should be encouraged. It's not something that should be encouraged, because it is going to injure the handler, and also the patient will not be comfortable, most especially if it is a dependent patient. In a case like this, that much of the work is being done by the handler or the handlers. So that should be discouraged in its entirety. I think that is the contribution I can give now. Thank you.
Thank you so much. That's a well-detailed contribution, Mr. Joshua. Thank you so much. Anybody wants to add on the picture? What Mr. Joshua has really covered a good point, but anybody wants to add on this? Yes, Bukayo.
Okay, thank you very much. Thank you, Mr. Joshua. He has raised a lot of points here. And well, I just want to add to what he has said. Considering the the patient and also the physiotherapist in question, or maybe the handler.
Yeah.
Both of them are actually susceptible to injuries.
Absolutely.
Looking at the, let me go to the number 3 picture.
Yep.
Lifting the patient here, there's every likelihood that the patient might have a repetitive strain injury on the shoulder, which you'll be treating again.
Yeah.
We don't know what they're treating. So the orthodox lift also, as he has mentioned, both lifter will come down with serious back pain with the height of the bed. And as he said, the Australian lift in no-go area. And the same thing also goes for the 4th one, which is the drag lift. The patient might likely suffer some injury in the shoulder. And also, there are other ways that this can be used properly and everybody will be safe. Thank you.
Thank you so much, Mr. Bukaya. Just to ask, let's say there is no equipment, and what are the alternatives? We say there are other ways. What are the possible ways that we're looking at for? Anybody, or people that have spoken, or anybody, what are the alternatives? If, okay, we've canceled the Australia lift, but the rest of it, if there are other ways, what are the alternatives? Let's say there are no equipment, which is, I know, is our challenge. Yes.
If there, sorry, I'm speaking now. Still,
that's fine,
Joshua.
Yes.
Joshua is still speaking.
Yes, please carry on, Mr. Right. Joshua.
Okay. Now, like we have said, instrumentation in this case, so we are not looking at maybe the hoist in this case, but
no,
like you have said, bed materials also, just ordinary bed materials that we have that we even if we don't have the custom made one, but with the understanding of what is needed. Bed materials, ordinary bed materials can help in alleviating and mitigating a lot of risk that we might have in engaging in handling the patients here. And we have also talked about with the understanding there is no harm. I mean, it's not serious request if we say, okay, the bed that the patient is lying on is good enough ergonomically for the handlers and the patient himself or herself. And again, if there is no instrument, what we need to do is to put our biomechanics or the science of biomechanics into. That is why we went through the center of gravity, the base of support, the line of gravity, all these things. So as a physiotherapist or as health professional, we need to put all this into play when we begin to handle our patients. So in order to actually guide against a risk of injury for both ourselves and our patients. I think if there are no equipment, what we need to do is make some improvisation, and apart from improvisation, put ergonomics into play, put biomechanics also into play. Those are the things that we need to do, all to just know that we minimize the risk of injury. I think that should be at the back of our mind. Injury to ourselves, the professionals, and injuries to our patients also.
Yeah, absolutely. Thank you so much. Now, these are wonderful contributions so far. And I think the message is, I'm really pleased, the message is sort of very clear in terms of minimizing, the bottom line is minimizing injury to yourself and as well as to the patient. Yes, equipment will be in an ideal world, but in the absence of it, that doesn't excuse us from putting ourselves at harm's way. We can do better. Now, if I would suggest, if I'm looking at this, if I start probably from the bear hug, now we don't know the condition, all those things, but and the bear hug is widely used. Now, if we are transferring a patient from one point to the other, it's the question of if the patient can be able to stand up or if the patient has that ability. If they have any sort of ability, what I also could possibly improve here. Now, yes, I can't take away the fact that we always use the bear hug in low resource settings, and it's hard to always take away that bit. But what we can possibly improve is think that you have two chairs, okay? One is the one the patient is sitting, and the one is the patient is transferring. What I will do is that I will put them at an angle whereby the one they are at an angle where the one the patient is sitting, the one the patient is going to transfer it into is just at slight tilted towards the one that the patient is sitting. The legs of the patient, I would probably position them in the direction of travel to the new seats. And if the patient because what I can see is that the person is trying to stabilize the affected lower limb. So what I will say is that the patient will try to reach across to, if they are just transferring, not necessarily standing up for rehab and things like that, if they are transferring to the new seats, I will ask the patient to reach using their hand that is able to the opposite seat, and I myself will probably be sitting in a chair in the front of the patient because this is half standing. Both of us might fall down anyway, but trying to avoid that, I might decide to sit in a chair in front of the patient, stabilizing the affected limb. I may ask for a second pair of hand who will stand behind the patient, supporting the upper body. And all I will ask the patient is, without standing fully into standing, with the legs in the direction of travel, they will pivot, whereby they just come forward like they are going to do sit to stand, and then the person behind will manually guide their body towards the new chair, and then they will sit down, and then I will adjust the chair. But that is in an ideal situation if equipment is not luxury. But again, if they have to stand up, then yes, they have to stand up. What I probably said is that the risks of both of you falling, then the therapist needs to be aware of. And with the patient grabbing you, if they become afraid of falling, they might decide to drag you all the way to the floor. And these are all the risks associated with this type of manual patient handling. And you reduce it by trying to see where you don't necessarily get entangled with the patient, if you can avoid it. The second one is they are practically pulling the patient. If we can look at the first guy standing at the top end, it seems like he's dragging the patient from their shoulder. And then the other one is the second handler is holding the legs of the patient. It's more or less pulling the leg of the patient. And the patient's weight it might fall in between the middle. Now, with this, also, it depends on the ability of the patient, because what I probably will do is, if there is any possibility of working with the patient to roll to one side and then to sit at the edge of the bed, and then from sitting at the edge of the bed, then we transfer the person to sitting rather than dragging them all the way from bed lying, supine lying, all the way to chair. Now, the second bit is the question of if they are all completely paralyzed, then I think that's where the modification of using the bed sheets, whatever sheets, rather than pulling them up and down, a better way to do it. And even if you are pulling them up and down, maybe a bit more people, maybe suspending them rather than the one underneath, rather than pulling the leg, just supporting the knees as well as the leg rather than pulling, just suspending the weights, if that is an option. And then the third one also is the same thing people mentioned. I think one thing is try where possible avoiding pulling patients from the shoulder. That's what I would say. Avoid pulling because it might cause injury, which I think the other speaker talked about. Where possible, try avoiding pulling patients from where they lock in their arm and they are pulling the patient. Use the pelvic girdle. You know, the shoulder blade is a nice area to hold and then to use it to facilitate the transfer of the patient. The shoulder blade, the pelvic girdle, these are big points that you can place your hands and move the patient. And with this, the third one, you can see the patient is way into the chair, his or her chair. So I will probably properly place the patient foot, make them to displace their weight using the principle of biomechanics forward to make it easier for us. We don't have to pull the patient. Let the person come forward as far as possible before doing the transfers. For the orthopedic lift, it seems like the person has a bit of strength because for the person to use their hand across the patient, it's going to be too much for the handlers, the people moving the patients. So it's the same principle that we applied on the second picture could possibly be do and to mitigate this. I guess the Australian lift is trying to lift a patient from the floor. We talked about falling patients. If the patient can do backward chain, try to do backward chain. If they cannot do backward chain, try to manipulate them whereby you don't have to bring their weight all the way from the floor, all the way to sitting and standing. Try to find another alternative way to bring the patients up from the floor. And then the drag lift is also where they are holding the shoulder of the patient. It's training to the patient. If we don't have equipment, of course, I know most places we use slide bed sheets, but think of your bridging. So bridging, for those that are not physiotherapists, is basically where the patient's lying supine. So by supine means lying on the back, on their back, bending their knees, and then ask them to push through, and then you are supporting them to come up where possible. It's a nice way to lift, to push the patient, enable them to do. Now, it's all about what other people have spoken, maximizing maximizing the resources you have, utilizing the knowledge to make sure that you minimize injury to both you, everybody that is involved in the handling of the patient. And let me come back to my equipment. In summary, if you want to summarize those equipment, these are called transfer aids. These are called transfer aids. The first one with the blue, not the two blue dots that we looked at earlier on, with the blue in between with the white bar, which is the one that will be available for the practical training for those that will be around. So the first one will be available for the practical training is called a rotor stand, and it's used for transferring the patient. And the second blue one with the dot, which we considered earlier on, is called the Serra Steady. It's also used for transfer, which we talked about. And then the third one is the Rotunda, the one in the box. And then the fourth one, the red one, is the return or more lift or patient turner, which also we talked about. Now, these are all transfer equipment, but again, I know each equipment is a luxury, but where possible, these are used for transfers. They are not for transporting patients from one pit to the other. We looked at slide sheets. Slide sheets are meant for bed positioning, and certainly it's something for especially patients that are bed-bound. It's very important for them to have slide sheets. If they don't have the custom made, think of the customized one. If they don't have the customized one, think of what do you call it? Think of finding something as an alternative. Now, we've already started talking about this already with our last point, whereby talking about the barriers to implementing all those things we've been talking about, and then what are the alternatives to finding the solution. But I will still ask the question again. Everything we've talked about, nice, brilliant. Is it possible for you to apply it in your practice? That will be the question. Is it possible, do you think, is to apply it in your practice? And if it is a yes, that would be brilliant. If it is yes, what are you going to think of applying in your practice? What are you going to apply in your practice? And if it is a no, why is it a problem and how can you go around it? So is it possible to apply the things we've talked about in your practice? Which one are you going to apply? If it is not possible, what are the barriers? How can you go around it? I will invite people to comment about it. What we've discussed, is it possible? And I think it will be nice for you to unmute your mic. I know it's good chat function, but please add a chat function if you can't. But I want to hear your thoughts around this, a bit of reflection of implementation of what we've discussed today. So I'm just gonna, anybody wants to add a bit? Yes, I think Suleiman add in the chat that yes, especially manual handling. Okay. Any particular areas of manual handling that stands out for you, Mr. Suleiman, or all of it? A bit of reflection. What do people think about? Is it possible to implement it, and what are the possible barriers and solutions to that bit? Okay, using Zachariah means you mentioned using slide sheets. Okay, all the best with that. Okay. Now, back to my question again. I hope when you join the conversation, you have a point of, you have a reason why you've joined, and I hope you've achieved something today in terms of what you will going to do in terms of your practice. I hope you've achieved something today. Now, for me, when I started, I said probably at the bottom. Now, this is just the background, but my first thought is to provoke your thoughts around when you are seeing that patient, when patient relatives are seeing a patient and you are looking at it, when the patients are doing it, how can you make it more efficient, less injury-free, less injury, exposing yourself less to injury? That is my bit. But again, the first bit, but I want more also to introduce you to the concepts, the mechanics behind it, the equipment to use it, and things like that. And in the beginning, I mentioned that training does not make anyone immune, it's the systems and habits do. Now, training is just the first step of doing it. And it's good that you attended the training. But to implement it is another different ball game entirely. Believe you me, I've seen people, I've been trained also in manual handling, and I've sometimes fall through the and more or less applying those principles. But the more you think about it, the more you applied it, it's more easier, it's more efficient, and it's more make a difference in how you handle patient. And even your patient, in my practice, even your patient will give you feedback on how they feel with your handling in terms of less intrusive, less dragging, less strenuous to them. And I think that's what I want to encourage us to do. So do it more. For you to do it, you need the systems in place, and it's about your organizational policies, it's about the equipment available, it's about following the laws, all those things. It may not be necessarily something it will change today, but it's a conversation that has begun, which I believe in the morning when I mentioned the registrar was here in the morning before he joined another different meeting. And these are things that we should be advocating as healthcare workers, because it's not okay for us to be putting ourselves at harm's way, but advocating, but our employer also should make the environment suitable for us to be able to function. And the physiotherapy, the medical rehabilitation therapists board, I believe they are part of those advocacy to change the narrative by encouraging handling equipment, proper handling techniques, proper handling training to staffs generally, to enable them to serve patients better. So this combination of the two things will enable us to be able to work, really, to enjoy what we are doing. And today is one part of the conversation where we do the theory component of the patient handling techniques. The second part of the conversation will happen in a practical sessions, whereby we will consider the equipment and we will use the equipment in the practice. There will be the practical training happening on the 25th of March. That's the first day of the training, where myself and will be showing those equipment, using those equipment, or using techniques without the equipment on ourselves, models, from 9 a.m. to around 4:30 a.m. At now it has to be it is a fiscal schedule, so it's going to be at Federal Teaching Hospital, Gombe. They have graciously agreed to partner with us and deliver these sessions face-to-face in Gombe State, Federal Teaching Hospital, Gombe, on the 25th. And it would be nice everybody to attend, but I understand sometimes it might be difficult, the restriction of location, etc., etc. Now, on the second day, after the training, I will expect everybody to go to their clinical practice and applied the same thing we have demonstrated, not only learned theoretically, but demonstrated practically into their practice, into their clinic practice. That will be on the second day. And on the second day, there will be a logbook for those that are part of the training and those who want the certificate to be issued, to complete a logbook of their activity during the clinical hours or during their practice hour, and then send it back using the WhatsApp or the platform of or emailing back to the emailing it back. There will be email provided. So on the second day is a self-practice, whereby you go into your clinic and practice, or FTH Gombe. If you are in FTH Gombe, I will be on ground, and I will not be on ground all through, but I will be visiting. I will be around in the wards, in the clinic, in the outpatient, just to work with you, to support you on those handling techniques in the second day. And on the third day, if you are in the hospital, we will meet by 9:30 to wrap up and to review what we've done, a bit of reflection. So we go through the logbook you've completed on the second day, on the third day. But if you are not on ground on the third day, you can also join us online and to review the logbook or the reflection of what we've done. Just to introduce the logbook, I'm going to share my screen. So this is the logbook that we will be using for the practical. Just to introduce the logbook today. So the logbook, I expect it to be completed It can be electronic, preferably is digital conversation. I'm going to add this to the WhatsApp group. All you need to do is put in your details and put in the clinic setting. What type of setting are you practicing? And then we have the case-based learning. So for the case-based learning, there is no name of patient, please. No need to put name of patient, but just tell us about the patient age bracket. What is the diagnosis? What are the functional limitations of the patient? And what are the goals of the patient? And we want you to describe the handling scenario, the situation that is required you carrying out that handling. Is it bed mobility, bed-to-bed transfers, seat-to-seat transfer, or seat-to-stand? Your approach, what techniques have you used? So just describe it. It doesn't have to have a fixed name, but what have you used? Have you used any communication strategies in terms of telling the patient what are the safety considerations? When you use it, was the handling successful? How do you find it or not? What is the patient response? If it is a patient that is already on your caseload and you go back and then after the training, you've tried it on the patient, and then maybe if the patient can give you a bit of feedback on what are the difference and what are the lessons learned, and then you write a bit of how will you integrate these techniques into your day-to-day practice, and identify at least 2 strategies that you think in your settings that will improve patient handling in your settings. So looking at your settings, what are those things that will improve patient handling? What we want you to do is you just find a bit of literature of supporting your best practice evidence or guidelines or whatever you do. Link your handling approach. So what you've done, let it not just be, of course, it can be common sense, but is there any research evidence supporting it? So think of the principles we talked about of patient handling, center of gravity, line of gravity, base of support. Is there all those things that supports it? And then you should add a reference that you use to guide your decision. You need to submit the logbook, the completed one, on the 26th by 6 p.m. at most, Nigerian time, 6 p.m. Nigerian time. And then once you complete it, that will be what we will use to have a conversation on the 27th. So all logbook completed. And then on the 27th, on the 27th, we will now come back and then have a conversation on wrap up. And if there is anybody that has any sort of difficulty with what they are doing or any questions that they have or any difficulty with, or they want to ask me more questions on the 27th before we wrap up, that's what we will do. Yeah, so and I think that is the leaflet for the training on the 27th. Now, apart from this training also, just to further advertise, we have other trainings that are coming up, but these are online training on the 1st of April. Is it 1st? No, on the Friday before we have other training, which we will put on the chat on the WhatsApp platform. I think it's probably on the 4th of April, 1st of May. We have a couple of 4 or 5 training throughout this year, which are all online. This is the only practical training we have. And if you are happy, you can, if it's something that will benefit you, please do join. And for this year. Yes, and then we have a couple of trainings also in 2027. So watch out the space. We will also inform you. But 2026 training are all out. You can decide to choose which one you want to attend. For this training, the practical handling training, I think we have the handling training coming up on the 25th, 26th, 27th. All right, that's me talking a lot. I will keep quiet now and say, do you have any question or clarification? No? Okay. All right. I am aware that the people you've contacted that helps bring you on log you in. Special thanks to the HOD, FTH, all the people that supported the facilitation of this training. They've worked tirelessly behind the scene. I know there are a lot of people, and I know there is also Shiloh that is also working with me. And so thank you. What I will say is that please, if you have not emailed them the official, if your names is already there with them, that's fine. And your email, please let your email, because we will be issuing the certificate. We want to send it to you via email where possible. If your details are with them, we will aim to start sending your certificates out on Monday. But if your name are not with them, please reach out to them and forward it to them. If you haven't had your certificates by probably Wednesday or so, email us and then we'll try to get back to you. If there is anything, please drop us a message and we will reply back to you. Apart from that, I would say enjoy the rest of your Saturday and all the best with your practice with less injury. Thank you. And I will hang around if you want to catch up with me, if you want to ask me any question or anything. Thank you for the messages. Thank you for the emojis and clap. Thank you for the encouragement.